All right. Well, good morning, everybody. Today is April 11th at 1:33 p.m. We will be joined, I'm sure, momentarily by our colleague and friend, Councilmember Sales, but I'm joined by Councilmember Lukey. We are here in the HHS committee to kick off the budget deliberations of the Department of Health and Human Services. And let's start with some fun stuff. First, we want to welcome back Ms. Clemens Johnson. We're so thrilled that you are doing well and your family is continuing to grow, and just thank you so much, Ms. Clemens Johnson, for your continued dedication, but it is great to have you back. Happy birthday to Dr. Bridgers. His birthday was yesterday, a little belated, but wanted to take this opportunity to wish him a happy birthday. And we have an administrative celebrity among us. Ms. Linda McMillan is back, helping us with this year's fiscal operating budget. But the team has once again done a fantastic job and not missed a beat. And so we have several items on this morning's agenda. We will begin with an overview of the HHS operating budget. We will then begin our discussion specifically with the Office of Aging and Disability Services. We will then discuss behavioral health services, and then round out by discussing Executive Regulation 00324, Crime Victim Compensation Fund and alterations. But before we get started, I wanted to say a couple of things up front. One, there is an acknowledgement and continued thanks and support for the remarkable work of this department and this agency, who continues to lean in on what have been unprecedentedly difficult times. I see Dr. Bridgers and his team everywhere, and we so appreciate, on behalf of the entire council, your dedication and commitment. I was pleased to see the executive's recommended budget, and while we will go through those deliberations, I did want to mention up front there, of course, are 80 positions that have, and I'm going to put in parentheses, new positions that have been added, but that doesn't tell the complete story, and we will, as we go through, recognize that some of these positions have been annualized, some of them have been converted to contract to merit positions, some of them are positions that we have funded and had been funding through the federal grants and budget that we had received through COVID. And so while technically, for purposes of an operating budget discussion, they are new positions, these are not necessarily new programs. They are continuations of programs that have been critical and literally served as a lifeline to thousands of county residents, especially over the last 4 years. So I just wanted to acknowledge that up front. Which begs the question, in terms of rules of engagement, of course I read, and I know all of my colleagues did as well, the memo issued by our council president, and it is of course the council president's prerogative, and I know this firsthand, to dictate what the process will be as we go through budget deliberations. It's one of the responsibilities of the gig, and understandably, Council President Friedson has highlighted, as he should, as we all should, the importance of fiscal responsibility and looking at all particularly new programs with a fine-tooth comb. But I just want to once again acknowledge that in the case of HHS, that's a little bit more complex because, again, in the eyes of the beholder, they may appear as new line items, but they are in fact not new programs. And so just wanted to set those expectations as we go through and adhere to the guidelines set forth by the council president, but also acknowledge the reality of the situation at hand. So with that, I will turn it over to you now, Ms. Clemens Johnson, to provide us with an overview and walk us through the first part of the packet.
Thank you so much. Excuse me. So for the FY25 budget, recommended budget for DHHS is $511 million. This is an increase of $35.1 million above the FY24 approved level. So sorry. Of this increase, $34.3 million is in the county general fund, $1.5 million is in opioid abatement funds, which is new for FY25, and a reduction of $717,000 in the grant fund. There is a total of 66 FTE increases recommended for DHHS, an increase of 3.4%. The largest increases are in public health and in administration, but I do want to note that in services to end and prevent homelessness, there was a reduction of the ERAP funds of $14 million, so you can consider that as well when looking at the largest increases. As the chair just mentioned, Council President Friedson sent out a memo outlining his intended approach for reviewing additions to the operating budget, just reinforcing what the chair has stated, that each tax-supported increase for new or enhanced program services and/or positions recommended by the CE or the council will be placed on the new and enhanced program list. These are generally items that would not go beyond a same service budget. So programs previously funded by federal state funds that are switching to general funds will be considered new or enhanced programs because they are new use of county tax supported funds. And also part of the request was that, or part of the approach is that council staff should also identify potential reductions to the department-based budget for the committee to consider. So council staff is instructed to identify reductions that would have the least amount of impacts on residents and should focus on ongoing expenditures. So as we look at the reports for the different service areas, we outlined the calendar at the first part of the memorandum. We will structure the staff reports for the committee review according to these elements with a new and enhanced program list, shifts that we see ongoing, and the potential reductions. Over the past few days, the 8th, 9th, and 10th, the public hearings were held. There was no testimony to include for this staff packet at the time, but we will incorporate that information as we go through the different service areas related to specific budget or program items. I'll stop there to see if there's any questions.
Thank you so much. I'd now like to give Dr. Bridgers a brief opportunity to share his perspective and overview from the executive branch's point of view.
Sure. Good afternoon, and thank you, HHS Chair Albornoz, Councilmember Lukey, and Councilmember Sells. The Department of Health and Human Services is delighted to present this afternoon and in subsequent weeks the county executive's budget. We spent a lot of time. Last year, when I was the interim director and now serving as the director of the department, I promised that we would really look at our fiduciary responsibility to not only the department but to the county. And so our team, we have an amazing team, as you referenced in your opening remarks. And we sat down and we really tried to unpack what it meant to the department to provide those much needed services. Some were funded last year and some are presented, as you indicated, again this year because they are need-based. Dr. Davis has done a wonderful job in our public health team in really walking through those county health metrics and forming those metrics to craft a county health improvement plan. Dr. McGee and Dr. Santiago and Ms. Treadvans and Christine Hung have all walked through the budget to really look at what's needed. They aren't here today, and in subsequent meetings with the council, they will present their service area. But the crux of the matter is there are needs post-COVID that we have addressed, continue to address, and will address in the future. Some of them are need-based, some of them are physically based. And so we look to continue our collaboration on behalf of the county executive to present a budget that works for the community. Last year, you charged the department with submitting supplements that were need-based. Last year, we submitted 13 supplemental requests focused on our reproductive health, our maternal and child health, our services to end and prevent homelessness, the Office of Food Systems Resiliency. So we listened and we provided the response. And we anticipate that during this discussion, we will again address some of the council's questions. But we really took time to unpack and really think about those fiscal needs that really will impact the community. Thank you.
Thank you. I guess as we go through, the team will introduce themselves, but thank you all so much again for being here. So Ms. Clemens-Johnson, I'll turn it back to you.
Thank you so much. So as part of the budget process, the departments and DHHS answered questions to the FY25 operating budget equity tool put out by the Office of Racial Equity and Social Justice. There are a number of questions that are asked and the departments are scored, and those scores are out of 11 points. DHHS received a 6 out of 11 for their score, and they are one of the departments that was asked to go through and provide some specific programmatic comments on 3 different areas, which are detailed in the packet, but they say normalize, organize, and operationalize. And so when it comes to their racial equity action plan, how do they implement this and carry out their work within the department? Just council staff comments note that that the score was a 6 out of 11. Last year, the ORESJ also said that the department is meeting the requirements outlined in the rubric, and in some cases go beyond. But the work that DHHS has done began prior to the passage of Bill 4420, and so the department is not in complete alignment with the racial equity lens. So we suggest that HHS committee ask DHHS to discuss how they will work with ORSJ over the coming year to come into alignment, or provide responses that on the tool that better describe the alignment with the framework, so the department's overall score might better reflect their long commitment to racial equity.
Dr. Bridgers?
Absolutely. This is an area that is need-based, and we recognize the fact that within the department we need to strengthen our response and become aligned with Bill 4420. It predates the actual bill and some of the work that we're doing. We're working closely with Ms. Ward in the Office of Racial Equity and Social Justice. We have ongoing conversations. I've asked Mr. Hodge, through his role as our Chief Operating Officer, to set up a schedule of meetings. And so we understand that we work very hard to strengthen our response, to make our work more equitable, but we really need to unpack and have targeted meetings with agendas that focus on how we can realign with Bill 4420, and to really unpack that. Once we do that, I am sure that we will increase our score. We're over halfway there. Once we become aligned with what the bill entails, then we will be more consistent with the overall rating of 11, and that's when we have a conversation. Hopefully this time next year, we can say that we have increased our score, and we are maybe 1 or 2 points off of the targeted metrics.
I appreciate that. That makes sense. We're building a plane while flying it, and I don't think anybody believes honestly that racial equity isn't a core principle of this department. It always has been, it always will be, and it's critical. We also have to understand that we're dealing with the needs of the most vulnerable populations, and the subsets of racial equity within those populations are very important to focus on, but acknowledging that you all are addressing the needs of our disability community, our aging community, and everything in between. And so it is complicated work, but it is very important that we align ourselves not just with the bill for purposes of administratively aligning ourselves, but of being able to authentically tell our story to county residents so that everyone feels comfortable and confident with the services that are rendered. And we know we are, but we want to make sure that our public is as well. Colleagues, did you have any comments? Councilmember Sales?
Because I know before I transitioned to the county council in the city of Gaithersburg, we went through our own internal racial equity and social justice training with the GARE, and I'm wondering how many senior level staff in the department have completed the GARE training.
So, Councilmember Sells, that's a great question. I don't have those numbers before me. I know that we have, on an annual basis, all the training that are delineated in the package. We have increased that in increasing culture, implicit bias, building blocks. In looking at, again, going back to aligning what the bill details, I can provide you with that information, but we are really looking at all of the levels of operations within the bill that we need to align ourselves. We really want to walk the walk and talk the talk.
Yes.
And so in order to do that, we really need to look at all of those precepts that are there, to normalize it, to operationalize it, to put all those things into practice. But not only from a racial equity and social justice standpoint, but from the work that we do. How do we do the work? How do we build capacity and infrastructure? And then not only building that capacity and infrastructure, how do we sustain those platforms? And then lastly, how do we evaluate them to make sure that we are reaching those targeted populations who are at greatest need? That's how you build equity. That's
Yes.
how you level the playing field, in my opinion, and the data shows that. So,
Definitely.
So that's my intent, and my senior leaders are committed. They tell me in those areas. So it's that type of bi-directional conversation that we have, because there are some things that I think may be equitable that may not really be equitable based on their program levels. So I look towards their leadership and their intimate knowledge of their service areas as our chiefs, as our leaders in HHS, to help inform me so that we can work collaboratively internally and externally.
So that's the basis of GARE and getting everyone trained, so everyone has that foundational knowledge across the department about the areas, opportunities to reflect racial equity and social justice in programs, in how you're evaluating staff annually. I mean, the trainings, those are ongoing trainings that, we are all required to take, but this foundational experience, I think it was 2 or 3 days of trainings that we had to do collectively as staff, so that there was a shared understanding and an accountability. And it's an excellent program, and yes, would love to see staff, especially in HHS, that serves our most diverse populations in some of the areas that we oversee. So, yeah.
So we do have a consultant to support some of that work with Dr. Crawford, and Ms. Treadvance was instrumental in bringing her to HHS to look at our individual diversity and across SLT, so that our senior leadership team just completed that training 2 weeks ago. It was brought to my attention. So we are moving in that direction, and this is where the team helps inform me, because there's a lot going on,
Yes,
but I want to
yes.
remain focused. And so we are a team. It's a collaboration.
Definitely, yes. And I would encourage everyone on the team, every single person from our chief of police to our city manager, and all of the council members actually went together to the training, because we wanted to have that shared understanding that even though we have different backgrounds, we approach things with our own personal biases, we need to understand that the people's work has no biases, and we all have to come from the same level, and that training helps center that and provides that foundational learning and experience.
Absolutely. We're doing that now. Thank you, Dr. McGee, for reminding me of that.
Councilmember Lukey.
Thank you. On this particular point, and talking about the metrics that you're currently using and working to align more closely with the bill, and I certainly appreciate that, and I appreciate the work you do with community stakeholders to set strategic plans for different programs and things, and that's your framework. But then I guess my question is, how are you embedding in that, once you've done a strategic plan, how are you assessing and reassessing, designing and redesigning to make sure, because none of those are, they're living documents, if you will, and they're guidelines for how you approach the work. And then there's the actual day in, day out. And so how are you looking at that to figure out what needs to be done for ongoing monitoring and tweaking and adjustment, so that you're maximizing efficiencies and maximizing reaching all the people who need to be reached?
Thank you, Councilmember Lukey, for that question. So internally, we've begun to look at those evaluation points that we need through either a Plan, Do, Study, Act model for evaluating the effectiveness of programs, but not only the racial equity and social justice platform, but those programs and models across HHS. We've had conversations with our great boards, commissions, and committees to look at evaluation practices. Some of the questions that may come up later that Dr. Davis and I have talked about is evaluating the effectiveness of our programs. Are we reaching those targeted population, even those that we have been monitoring or who have implicitly demonstrated a need, but implicitly we know that the data points suggest that there may be a need and we need to address those needs. And so looking at an evaluation platform is part of that strategic plan. In your budget round last year, we talked about a strategic plan, and we have a roadmap, and we've been working on an iterative strategic plan, but we have 75 to 80% of our senior leaders within the Department of HHS, especially at the executive level, are new. So we're building a team, and we're looking at all of our strengths and our capabilities and our ability to respond individually and collectively. And so as we continue with that iterative plan and that strategic roadmap, that's where I indicated that I would bring external stakeholders to the table to help us create a plan that really addresses the strategic needs of the county. And so we are building that and incorporating and including that process. We haven't gotten there yet, but it is part of that framework. It is part of that, and we haven't started from scratch, as they say. We've used previous roadmaps as lessons learned and as a framework to move forward. We know that there are things in COVID that we were doing and that we were able to do, but we no longer can do. And how realistically can we get that work done? And so that's how we're doing that. And we are evaluating and including more evaluation, which is tied to the funding, to demonstrate how we can help those programs build capacity that really reach those unmet targets. Evaluate them to determine if more money is needed through enhancements or future fund initiatives. So that's our approach now, looking at after a year. Fast forward, all of these practices we've begun to put in place, and we have done it collectively and cooperatively with the executive branch, and now having discussions with the legislative branch. So that's our approach.
Thank you, and I certainly appreciate it. I know when you and I first met, you were talking about coming in and being in this role, and of course, in a new era, if you will. And yet a tough era in terms of need and things going on. But a lot of the types of housekeeping, as you say, of an administrative agency's work and executive branch agency's work, especially in an agency as large as DHHS that was so critical to the COVID-19 pandemic response, couldn't get done because every day was a fire to put out, and so I know that I appreciate. Thank you for saying that you've spent the past year working on. As I don't want to imply that that's all you've been working on. Heaven knows that's not true, but that you've spent that time sort of taking that lens to everything, because it is critically important in figuring out what needs to be done, who needs to be served, and the what are we capable of for the moving forward. So thank you.
Yeah, I'll just also know I agree very much with what my colleagues have said, but HHS is in somewhat of a unique situation. You all have to administer federal programs which have their own set of guidelines that don't always perfectly align with the county's intent. There are many examples. One of the most acute, we've been talking forever about how to better break out demographic information, because we do this based on the federally mandated census data, but we know that doesn't tell the whole story within our Black and brown communities, and we need to get there, and we acknowledge that. So I think that also presents an opportunity for us to go beyond the guidelines of the law as it pertains specifically to HHS, and you all are headed in that direction, I know. So, and we of course have key stakeholders and partners. Our minority health initiatives and program are prime examples of that. So we've got some work to do, obviously, but we respect the work that you all are doing and know that you're going in the right direction. Ms. Clemens Johnson.
Okay. So our next item in your packet is the council staff requested an update to the HHS committee on the role of the chief medical officer and how that has evolved over the last year. This is a new position within county government, so we thought it could use some prioritization in terms of discussing it during the budget hearings and understanding the role as the chief health policy officer, reporting directly to the director rather than having a service area that this position is responsible for. So the packet details the responses that were given to the department, but I did want to note that Dr. Davis has taken the lead on some strategic initiatives that the council has been engaged in as well, that namely being youth safety, overdose prevention. They noted that she is elevating the clinical practice across the department in terms of dental, behavioral health, and also sharing her expertise with departments like corrections and the Department of Environmental Protection within county government. Part of the packet also details her focus in FY25. I did want to call out that one thing that was noted is that she wants to address the lack of adequate care and resources for persons with sickle cell disorder. That is something that the council has heard, and I think is just trying to understand the complexities that when it comes to that need for residents in our community. Also noted that racism as a public issue, that was something that the council undertook a few years ago. And I don't think there hasn't been much movement on that. And so I think that is part of the work that Dr. Davis will engage in. So I just wanted to highlight that, and I'll stop there. And
Thank you. Dr. Davis, how is the transition going with the new structural framework of the department?
I think it's going well. 15 months in, and I'm still here. Since assuming the role, I'll just give kind of a brief overview. Ms. Clemens-Johnson touched on a lot of it. Been focused on several key health initiatives, improving health outcomes, and reducing disparities across the county. Have served as the primary spokesperson for COVID-19 response, ensuring clear communication and coordination with DHHS and external stakeholders, in addition to chairing the Overdose Prevention Task Force, leading efforts to address the opioid crisis, specifically on the rise of fentanyl, and worked collaboratively across departmental boundaries and other agencies. And as also was mentioned, starting to lead the Youth Safety Initiative Task Force, again, pulling in partners from across the county government. And I think that was really part of the focus in creating this role, is being able to work collaboratively within the department, so to reach across and collaborate with behavioral health and aging and disabilities and children, youth, and families in ways that was hard to do when you were solely focused on public health, but also being able to reach across county government and have those deeper collaborations with the school system, with corrections, with many county agencies. And so I'd say that's going well. There's a lot of work that has been done, a lot more work to be done.
Thank you. Questions, colleagues? Councilmember Lukey?
Yep. Thank you for all that you've been diving into. And I'm curious, I know one of your goals was focusing on patient expectations for care in clinics. And so could you talk a little bit about that initiative and what that means, both, the how you're doing it, and then of course the why it's so significant as an outcome?
So right now, our county clinics operate pretty independently of each other. Behavioral health is doing one thing, our dental is doing one thing, our HIV is doing something else, and so have worked closely with our practice management credentialing team to bring some alignment into that space. And I think one of the things that we're finding is that it would be good for us to have some consistency around what patients should expect at our county clinics. We are also looking to do a study with our clinics to see what is the processing for patients as they move through the system, to better understand what that workflow looks like. That will also enable us to be better able to potentially bill for services to take advantage of expansions in Medicaid. So we are at the beginning of that work. A lot of that is looking at what do we have now, where are some of the problems where folks are bumping up against the system, and I would hope to eventually get to the point where we have some sort of patient expectation handbook that we could give out.
That would be awesome. Thank you.
Thank you. Councilmember Sales.
Thank you. Dr. Davis, we're glad that you are still here and we haven't scared you away. Just wanted to ask about the youth safety initiatives that you mentioned in this the response. I know that we've seen an uptick in violence and in juvenile delinquency, and just wanted to know, since we no longer have the referral program through the courts, how are you working with our, I guess, at-risk populations, and just wanted to hear more about that.
Sure. So in terms of the court program, the court magistrates and state's attorney are part of the collaborative in terms of the group that's helping to inform it. So their voice is at the table. I'll also say there's a big piece for community involvement that we are trying to bring in the community and bring in that community voice. We are just at the very beginning of launching things and forming things, but have looked at some of those community convenings have already happened. I know PYD and Street Outreach Network hosted a series of events last year that we're pulling information from that, working in collaboration with Collaboration Council. We've had conversations with Identity and other organizations in terms of what they are hearing from the community and how we bring that into the conversation in what's going on. I'll say, the focus that we're looking at for this is, one, getting better data. The data that we have is scattered and inconsistent, so having a consistent data dashboard that tells us about youth safety, looking at our communications, our policy, and our programming. We had a consultant that was really helpful in trying to understand the space and what we have, and what the main message from that consultant was, you guys really need to have a stronger foundation before you can even get to the plan. And so identifying who's at the table. I'll say the other thing, when we're looking at the initiative, and the reason why it's called youth safety and not just gun violence or violence prevention, is because when we look at the core, we have also seen an increase in substance use in our youth. We've seen an increase in self-harm and suicidality. And while those manifest differently, some of those root causes are the same. And so our youth are really calling out to us to say that they're struggling, and so we are trying to look holistically at what are some of those issues that can affect and impact and improve the lives of youth in many different facets.
Thank you. I noticed that you mentioned you'll be, working to develop these plans, and I'm hoping that we will align that with our geographical data. I know we did a groundbreaking study maybe a decade ago with Dr. Gales that went down to the zip code on data for across the county. And so I don't know if this would overlay with the data collection that you are thinking about for creating this baseline level of information.
It will inform it in some way. I will highlight that we just updated our zip code ranking project that came out just about a month or so ago, as well as our health equity data. And so that information is also just recently up on our website. And for Primary Care Week last week, we had one of our preventive medicine residents who went through and did a walkthrough of some of that data that tells a little bit about our community. So happy to share copies of that after the presentation.
Oh, good. I just had a meeting with one of our minority health initiatives, and they spoke about these community health workers. And I remember in college, I was a community health worker, and I was tasked with asking the public specific questions related to a specific study. And so I'm trying to understand what their work plan is, what they are being tasked with, and every initiative has different contracts with different providers that have different tasks, and it's not clear what they're being tasked with. And so it would be helpful if they were aligned with the focus of evaluating our public health needs, our public health priorities in the community. If we're paying those contracts to go out and especially culturally competent community health workers, it would be good for us to be able to utilize that information and better understand how they're being used and how the information they're collecting or the work that they're doing is aligning with the overall vision of HHS.
That's certainly something we can look at. We use community health workers in a variety of different programs in a variety of different ways. Looking holistically across the department on how we're using community health workers in those different respective fields is something that we can certainly investigate.
And just to add, Councilmember Sells, I know that Dr. Davis and I have had conversations about this when she convened and a countywide agency senior level executive meeting with all of the agency leaders, but we're also looking at those community-based organizations who are doing similar work. And we need to realign those capabilities from a fiscal standpoint. We also talked about micro grants and some of the micro grants that the Asian American Health Initiative did, and it's a successful program. So looking at different models, looking at a coordinated effort at the macro
Coordinated.
level
Yeah.
and at the micro level, because we know that folks at the macro level may not know what those folks at the micro level are doing, and some of them are
Exactly.
overlapping, and we need to look at the costs for the work. They're all doing the great work together.
Definitely.
But we need to really focus on coordinating that effort. And I know that that's part of Dr. Davis's Health and All Policy Plan and some of the Youth Safety Initiative. And I'm just going to go on record and say that I am glad that she's here and she's a partner in the practice that we do in HHS.
Awesome. And then I did have another question about you mentioned the sickle cell initiatives. I'm not sure what the standards are or best practices are for hospitals, but I had a hard time getting information from our county hospitals. We're still waiting for information from the Maryland Hospital Association, so I don't know if there's a national standard for best practices or the what sort of response those patients are supposed to receive when they seek treatment. And I know that their treatment is usually in emergency rooms, and Maryland has the highest emergency room wait times. And so just wanted to know what exactly is happening and who's overseeing that effort.
Sure. So this was really brought to our attention by community advocates around sickle cell, and I will admit that I was really shocked to learn about the absence of services for patients with sickle cell in our community. Many having to go out of the county to get adequate health care, and heard some really horrific stories of patients who had been treated in the county where things were missed, just not treated appropriately. And so that really elevated the concern amongst myself and other folks in the department. We've had several conversations with the advocacy group as well as some physicians. We are now working with the African American Health Program, actually brought this to the minority health initiatives and programs, and they all wanted to have a part. So when we looked at the data for sickle cell in the county, while it was predominantly African Americans, we also saw sickle cell in our Hispanic population, in our Asian population, our white population. And so the minority health initiatives and programs wanted to take this on collectively. So they are working with community organizations to set up an event likely in the fall, likely in conjunction with Sickle Cell Awareness Month, which is September. Starting with one, bringing awareness to the hospital community. We've also had conversations with Nexus Montgomery, and we'll be meeting with them regularly, which is the Association of Hospitals, to really help elevate the awareness that they have, and the hospital executives, at least at that level, were also surprised to hear about the level of care. So I think that there is traction that is happening in that conversation, and I will really thank the advocates who brought it to our attention.
Yeah.
It was something that had not bubbled up to the top, so I really thank them for raising the alarm.
All right, thank you.
Thank you. Good questions and comments. I'll just note also that your appointment to head up the Youth Safety Initiative, Dr. Davis, I think clearly demonstrates that we are serious about this public health and all policy approach. And so I was very excited to see your appointment to that position in making those connections. I think it's great. Ms. Clemens-Johnson.
For Section B, we'll start with the department-wide required changes, those that are no new programs or enhancements. They just include charges or annualizations needed to continue or maintain current services. Some of them are personnel cost adjustments. So the charges included in your packet, and if there's any questions, maybe the department could address them. Okay. Section C goes on to the department vacancies. As of March 25th, 2024, there are 288 vacant positions. 184 of these are tax supported, 104 are non-tax supported. There are currently 110 of the positions are in the recruitment process. And so as we go through the service areas, we'll highlight the vacant positions, how long they have been vacant, the type of positions that they are, and we will provide that information.
Yeah, Dr. Bridges, this was a big point of discussion last year. How are we doing? What's the update? What's going on?
Thank you, Councilmember Albernos, Council Chair Albernos. We've done a lot of work in this space. Last year, we had over 350 vacancies. In October, it was down to 328. In February, it went down to 265. We got the transfer list. It went back up to 290. We have put a lot of effort in this. I want to particularly thank Director Anderson in the Office of Human Resources. She came to our department. She met with our senior staff. We talked about models. We talked about pipelines. We talked about talent acquisition. We have a great human resource manager who just joined us, and she's been working with Mr. Hodge to really look at those tax-supported vacancies, those legacy vacancies. But 80% of our vacancies are clinically based. Social workers, clinicians, psychiatrists, nurses, and we know that there needs to be a different strategy. I've even had a conversation with the Maryland Department of Health, and we are all trying to recruit and retain many folks from the same resource pool. Look, we're looking at clustering hiring, we're looking at hybrid hiring practices, we're looking at modeling. I want to compliment Dr. McGee, who's sitting next to me. We had the training with the Office of Human Resources and their 30 days to hire model. She is actually piloting that model in our aging and disability services. It can be done, and we want to use that as a best practice. So when we talk about evaluating the effectiveness of the work that we do, this is one of those areas where we use an evaluation model of Plan, Do, Study, Act. So we are actually going through that process now. We have made significant strides to reduce the number of vacancies from last year, looking at Director Fasalo's model in the libraries and how she significantly decreased those number of vacancies. So we are looking at practices internal to the agency and externally to the agency, or external to the agency, I should say, and it's making some improvements. We continue to decrease and focus on not only those reachable and attainable hires, those programmatic staff that you will see later on in the package that we must that are much needed, and I won't steal Mr. Hodges' thunder. I asked him to walk through that, but we're looking across HHS. We're looking at those service needs that are realistic and attainable, and we've been doing that since our discussion last year. We've made some strides, and we know we still need to work very diligently in this area, but it is a priority. It was a priority coming out of the budget work session last year, and we've begun to implement and use those tools and resources that are available, that are cost effective, that are free in a sense, because we have some of those tools within the county government that we could use, and we've leveraged those tools. And so we continue along this endeavor, and we are, as Councilmember Alberno said, building the plane, but we are making that plane more conducive to the needs of the agency, which will impact the community.
Thanks. I'll just note a couple of things. Obviously this is a problem not unique to us. All sectors, public, private, and nonprofit, and all jurisdictions across the country are struggling to fill these positions for sure. And recruitment is important, and I very much concur with the great work that Ms. Anderson has done, really going more grassroots and understanding the needs of departments and agencies. Retention is also important too. That's clearly important, not just because it will prevent future vacancies, but also it's our own staff that are the best recruiters. And if they're happy, then they're telling their colleagues and friends and associates and universities that they've attended that this is a great place to work. So can you talk a little bit about some of the retention efforts, because it is directly related to this topic? Mr. Hodge.
Mark Hodge, Chief Operating Officer, HHS. We have we've done a lot of work on the recruitment side for sure. A lot of out of the box thinking. Retention efforts are a little more difficult, a little more costly, and so we're starting to look at and have those discussions. We did get some grant funding from the state to do for the school health nurses and techs a retention bonus. For the past 2 years, that worked out really well. They appreciated it. With any retention bonus usually comes a contract with the employee to stay for a year or two longer, or they have to pay it back. So that helps keep people within the organization. But we're also looking at other employee incentives, maybe not things that require large amounts of money or even bonuses, but re-implementing our employee appreciation committee, which puts together parties or a fall festival, which Dr. Bridgers and his team are now starting to look at again for the fall, to do something for the entire department out at Boer Park, which we've done in the past, but have not done for quite a while. So re-implementing some of those things is really important. We just hired a new chief of she likes to call herself chief. But we just hired a new manager for our human capital development and organizational development, who replaced Susan Sealing, if you remember her. She has a lot of tools that she's coming with around manager training. We are working really hard to change the culture about how we manage and supervise our staff. Sometimes that can create environments where it's easier for people to leave if they don't feel like they're being supervised or managed appropriately. And so we are. I've asked her, and she just started this week, so give her a little bit of time to jump in. But she will be really focused on management and supervisor training, and not just the how do you assign time cards, how do you do performance evaluations, but how do you motivate your employees, how do you keep your employees engaged, and how do you keep them happy. And so that's the big thing that we're pushing right now. I'm sure there will be things in the future that we think of that may cost money, and maybe some of those supplementals that Dr. Bridgers asked about previously may come into play. But I know that retention is a huge thing. It seems like sometimes every time we hire 20 people, 15 people leave, and it just and not. I don't think because they're unhappy necessarily, but we also have an aging employee pool, and so people are ready to retire. And if they survived COVID, at least the work of COVID, and are still here, they're getting ready to retire now because they all were committed to staying during COVID. So we're seeing a lot of attrition just through retirements, but we are looking outside the box for any way we can for recruitment and retention.
And the only thing I'd like to add, Councilmember Albornoz, is, and I give Mr. Hodge this credit for the work that he did when he was a senior administrator for our school health nurses. We use cluster hiring, and these events had a high turnout. We were able to not only recruit, but hire on the spot, absent of some of the other human resource requirements that come with the hiring. But it was a process where we were able to reach a wider population, and we're thinking about using this as a model. Piloting it during for social workers, for clinicians, and then look across the agency to see where those needs are. So rather than each individual service area trying to recruit X number of clinicians. Some service areas need 32 social workers. But if there is a robust resource pool, we can distribute and place those social workers across the agency where there are the most needs. So we recruit our clinical staff and then place them, and then it becomes need-based. Then it's not the number of vacancies we have, but where are those areas of greatest needs? And we have a cluster pool for that. So we're using and we're going to replicate that model within HHS. It is a new practice, but we want to develop it as a best practice. And so that's some of the strategic initiatives that we look forward to presenting to council in another setting, and to demonstrate the challenge of thinking and hiring folks that are much needed across the state and the nation.
That certainly all makes a heck of a lot of sense. I would just add, partners with our friends in labor, particularly in the space, acknowledging that we can really leverage the relationships and trust that each of us have in a way that's helpful and authentic, and hearing directly from the voices of staff themselves, who often have wonderful suggestions. And you want to manage expectations, for sure, within reason, but I have always found our staff in particular have great stories to tell and want to be part of the solution. So, but that all sounds like wonderful progress. Great, let's move on. Oh, sorry about that. Councilmember Sales.
Yes. Just wanted to know, I know you shared a few of the vacancies or the positions that are within the actual budget request that will generate, it says $1 million in revenue across these about a dozen positions. And I wasn't sure if that was part of the vacancies, or were those accounted for in the vacant positions, or are those?
These would be new FTEs for FY25, if you're talking about number 3, under section D.
Number 3, yes.
Yeah, these would be new positions.
Okay, so those are not accounted for in the vacancies because they're already being hired, or in the
They're new, so they're proposed for FY25.
Okay. Do you have a list of the vacant positions, the 184 tax supported and the non-tax supported? Are those just through federal grants, or what are those positions for?
So the largest number of grant-supported vacancies are in child welfare, where we have 34 social work positions, and that's paid through House Bill 669, so through MDH and the state. But the others are federal grants. Some of them are term positions that actually will be going away soon, at the end of September, so some of those might be vacant. They're in our vacancy list, even though we probably won't be hiring for those because the funding does end at the end of September. We have a large SAMHSA grant. Others, the ERAP positions are the same, also term positions, the Emergency Rental Assistance Program. Some of those are vacant, but we're obviously not going to fill them because at the end of FY24, that funding goes away as well. And so some of the grant funded positions are getting ready to end, and so we're not going to fill those. So that's a big chunk of the non-tax supported vacancies. Our county funded positions again are large numbers of nurses, large numbers of social workers. In behavioral health and child welfare, public health as well. And then we have others that are program specialists or program managers here and there that we're recruiting for. A large number of our vacancies, 110, are in the process of somewhere between posting the job and hiring. They're somewhere in that process. So a large number of our vacancies will be filled over the next month or so. Keeping our fingers crossed that doesn't mean that people will also leave, keeping our vacancy numbers higher. But the numbers will change probably drastically by the end of September because a lot of our grant-funded positions will be just gone.
Okay, and what is the current timeline from the posting of a position to the hire date? What's the average lag time?
Right now, the average is around 2 to 2.5 months.
Oh, okay.
So it's better than it was.
Yes.
We are working really hard. We've talked with all of our hiring managers to not wait for the eligible list before you set up your interview questions, set up your interview times, get all that on the books, find out who's going to be interviewing.
Mm-hmm.
So as soon as that eligible list comes, you can start making those phone calls to set up those interviews. So there's no reason to wait for every step to start the next part of the process. And so we've done a lot of work with that. We've been working really closely with our Office of Human Resources to get those eligible lists more quickly. We've done some more group hirings. So we have positions that are posted for social workers, for example, that it's not just one particular vacancy, but a social worker in child welfare, a social worker in behavioral health, a social worker in another place under one recruitment. And so if we get 25 applicants, we can interview them for any of our vacancies and not just post them for a specific place. So that's helped as well in shortening the time that we're able to post to hire time.
Okay. All right. Thank you.
Great, good question. Let's move on.
Sure. So the last part of our overview are budget changes identified in the budget document, not connected to a specific service area. Given the council president's approach, we will need to consider where these fall in our charting. And so there are listed items 1 through 3. I'll start with item 1, which is a one-time adjustment for higher than expected contractor costs at $3.1 million. The response that we got from DHHS when staff posed questions was that this item is to recognize that due to increased vacancies, the department expects to use additional contract broker staff and temporary staff to backfill vacancies for essential positions. Also, DHHS projects to use additional overtime. So staff's recommendation is that we split this funding into 3 tranches, tranche 1 of $1.1 million, and then a tranche 2 and 3 of $1 million each, and consider whether any of this increase can be reduced since there is an expectation that positions will be filled during FY25. It's categorized as a one-time item, and the department notes that if vacancies are reduced, it would not be needed in FY26.
Gamble, but I get it in principle, but I don't have an objection to it per se. But needless to say, we have to have these funds, to be able to carry out. We can't hit the pause button on the types of services that these contractors are having to fill as we go through. So I can't think of a better way of doing it, honestly. I think it's a reasonable suggestion, but we will have to underscore that this is not a nice to have, because as we go through the budget process, all of us are put in very difficult positions. We'll have a macro list of everything, and it will all look important. And it will be difficult to whittle our way through, and we're of course not doing any rankings this year, which I actually agree with, but I just want to make sure this doesn't get lost in the shuffle. I concur with the recommendation. I just want to make sure we really emphasize this through the budget process, and I will have a conversation with our council president about it as well. Colleagues, anything to add?
No.
No? Okay.
And for the next section. It's connected somewhat to the first one, is a one-time budget adjustment for higher than expected overtime. This request is $750,000. So the staff posed a few questions about what this overtime was attributed to, and DHHS noted the same response that they provided for the contractor costs. We did note that this increase is primarily attributable to the crisis center, which was, I believe, one of the only 24/7 services that DHHS provides outside of our shelter system, which is mostly run by contractors. So we're not talking about merit staff. We don't get into overtime. So understandably, it would be the crisis center. And council staff is not recommending a potential reduction, but just note the use of overtime should be evaluated for FY26.
Agreed, without objection.
Okay. And for our third item, this is a increased administrative infrastructure to new programs for the ability to build revenue. So this item is $980,902, and includes 11 FTEs. Council staff did pose who are these personnel, what areas will they be assigned to, and to please describe how the Medicaid revenue stream would work. DHHS provided a detailed response and gave a list of the positions. But at this time, staff is not providing a recommendation on this position. So the beginnings of the response for these positions had to do with the overall increase of the DHHS budget. So we looked at it in general there, but after this report was produced, we received more information from DHHS with the list of the positions. Not all of them were directly connected to revenue. And so we want to consider this as a follow-up item because we just received some more information. We would like to bring this back to you with additional detail and share with you how these specific positions will bring in revenue, since it is a total of 11 FTEs across some different service areas. So that is our recommendation, is that we consider this. I think our follow-up discussion is scheduled for the 29th, or we can incorporate it in any other part of the HHS committee work session. So we will bring back more information, and then our DHHS staff is here if there are any comments they want to add.
I think that makes sense, but when you bring it back, if you can provide some broader context as to, where these folks are going to live, who they're going to report to, how big the offices are that they would be part of to begin with. I know as a matter of fact and principle that the caseloads and I know the administrative staff is drowning with a lot of the contracts that you all are having to manage, which are growing in their complexity. And I don't know, I can't remember exactly what the percentage is, but a significant percentage of the overall contracts with our community-based organizations and providers are funneled through HHS. And I know that has presented some significant challenges. So if you could just provide that when we come back to this on the 29th, that would be very helpful. And I don't have anything to add at this point. No. Oh, Councilmember Lukey.
I haven't asked to go along with that because I think, I think everybody here knows I'm not a big fan of leaving money on the table, and so I appreciate the need for the administrative support to make sure that whatever we are able to maximize through Medicaid or other sources we're able to bring in, because that helps us to do the good work that we need to do out in the community. I think that it would be helpful to explain when you come back on the 29th what other challenges DHHS is having in the billing arena on the administrative support and program on the program side, like what specifically, so that we have a better understanding of the work that has to get done and how those 11 FTEs will engage in that work. I think that would be useful.
Thank you, Councilmember Lukey. We have a detailed spreadsheet with the positions, the grades, the full-time equivalent, but we will add the work areas and the information that you just requested to enhance HHS's response. So thank you for that question.
Thank you. Councilmember Sales.
Yes, I just wanted to follow up on the response to the council question about the significant increases that we've seen on the HHS budget. I'm seeing, we're anticipating a 40% increase, and this is mostly due to administrative infrastructure. And so I'm just trying to understand, as was mentioned, you all are overseeing a lot of contracts, and do you have any recommendations? Are you assessing or concluding anything from the experiences, any data collection that you're doing to see where there's room for improvement, to see where the inefficiencies are, and how we are working with our nonprofit partners, if there's a better department that should be overseeing these contracts, or it just seems like a significant amount of money, and we are decreasing the amount of grants that we are providing to nonprofits. So I'm not understanding what's happening with this area.
while a lot of our community grant contracts from the past have gone over to the Office of Grants Management, we still have over 700 contracts in HHS. The other piece of this puzzle is through the generosity of the county executive and the county council over the past 4 or 5 years, through COVID and even before, HHS continued to grow its program. New things pop up like youth safety or LGBT health, all of these things are important, but the infrastructure to support that from an operations perspective, from the back end for billing, for
not
invoicing,
sustainable.
for all those other things is never considered in that.
Mm-hmm.
We just grow the program and the staffing for that, leading to vacancies, but then we struggle to get things in time. We struggle to get the data that we need, and we struggle to get the contracts that we need with the third-party payers, with insurance companies to be able to get reimbursed. And so those things kind of fall by the wayside. And so we made a concerted effort this time to try not to grow our programs this year, and to put in these 11 infrastructure positions. And so that's where we're kind of hoping to be able to lead to is right sizing really the operations piece. Yes, a lot of it falls within my office of the chief operating officer, but it's those employees who are struggling now and not getting things done. I think all of the county council members have gotten a complaint or a gripe over the last year or so about invoices not being paid quickly enough. And as much as we try to do that within 30 days as expected, we don't always have enough staff to be able to do that. And so we have far more invoices than we ever had before. We have just as many contracts as we did before, even though a lot of our grants are now with the Office of Grants Management. And so this infrastructure piece is really, really important to Dr. Bridgers and myself and the rest of the department. But part of our increase is also making sure that we can continue the programs that we have that we may have had grants for. And so the increase you're seeing, Dr. Bridgers and everyone else on the senior leadership team really looked closely at all of this and making decisions about what to put in there. And OMB obviously helped focus us even more, and the county executive made final decisions about this. So if we had an unlimited supply of money, we would have. This might have been even larger from an infrastructure needs perspective. And so I appreciate the question about coming back with other infrastructure challenges, administrative challenges, because there are still more. And this year is just the first year that we'll be coming back with requests to right size our infrastructure.
Yeah, so we're seeing the same concerns in our MCPS budget. Significant money being spent on contracted work through nonprofits, but we're seeing low literacy rates in our third graders. We have high disparity numbers across the county, and so I'm wondering, we are seeing $137 million over the past 3 years go out the door. What are we getting for a return on our investment? How are we evaluating these 700 programs to serve our residents and evaluating them for their effectiveness? I just need to better understand what's happening here, because it seems like it's growing to a point where it may not be manageable. Like I cannot imagine how we're overseeing 700 grants, how we're evaluating them, how we're getting payments out 30 days at a time. I don't envy you, and I just want to better understand how you're managing all of this and still, confidently able to say that we are addressing the greatest needs adequately for our residents. And so just want to better understand that.
Sure. Thank you, Councilmember Sells, and thank you, Mr. Hodge, for providing some of the crosswalk. But some of the things that we're doing internally is we have Dr. Richard Nimhart in our program analysis and customer service division. She has worked very diligently with our other chiefs to look at management of contracts, to look at a Community Connect portal, to look at all those evaluation strategies that we've talked about this afternoon, and there is a greater need. It's interesting that you mentioned MCPS because I had a meeting with Dr. Felder yesterday to talk about the interoperability of data when we look at youth safety initiatives. And it's been a challenge, but I know Mr. Hodge and his team and his chief information officer, as well as our technology and enterprise business service agency within the county to look at IT and how we can really manage the data, knowing that there's a lag in data. But we have data, secondary data, that's available here in the county. So when you look at evaluation strategies, you have to be able to access that. When Dr. Davis talks about a health and all policy and a value-based care models and reimbursement models with the public health team, we need data. We need to be able to access that information. And so some of those additional positions that you asked that are included in this budget request that's been vetted with the county executive and OMB really looks at those needs. Look at a parallel relationship or correlation between what we can actually pay for and what we need support for. But many of those infrastructure resources will cost, but they're needed when we look at those operational data versus data mining, looking at those spaces that we have and those targets that we have traditionally evaluated, but needs to be looked at closely through a different lens. And so all of these practices we are attempting to put in place with this budget and with the additional staff, program staff, and looking at the office service coordinators and coordinating all the responses and follows. We talk about contract and grant acquisitions, being able to respond to those partners, those vendor partners in the county who do the work, but looking at the work that they do and how it impacts. One of the things that Mr. Hodge implemented when he came aboard as the Chief Operating Officer was to have an all-staff meeting to talk about contracts. Mm-hmm. How we manage that, how we use that data to respond, looking at the service gaps. And he asked all the chiefs to identify those targets and those spaces that we need, not only in his office, but the other service areas as well. And so some of that is an ongoing effort. It's a work in progress. And we need to be forward in our thinking in doing that. But we need to be realistic in those areas, in those staffing gaps that we have, and present that to council for consideration as they were presented to the county executive and his team. So there are things that we're doing regarding the infrastructure that continues to carry over, but they are necessary when we want to look at our strategic sustainable platform. And so we want to make it clear. Hopefully that answers your question. There are other nuances that are in progress that I won't share this afternoon because I need to make sure that my Chief Operating Officer and I are clear on the outcome of that. And that's part of that evaluation practice.
Yeah, and I think with 700 contracts, it would be good to find out what the areas of expertise these contracts are supporting, and then how we're using our health initiatives to carry out these duties, these requirements, these priorities. Because I imagine that every year we have these contracts, and sometimes we just continue same services, we continue to fund the same things over and over, and we're not reprioritizing what are we going to focus on this year based on last year's services, feedback, and the populations we serve. This is what we're going to do with the resources next year. And so we have to get out of this rut of maintaining these contracts, and we're going to have to take a closer look at some of these contracts because this spending is not sustainable.
One of the things I just want to add about our contracts, of the 700 plus contracts that we have, a third of those are non-competitive contracts. And so I've been working with our manager, with the contract management team, to look at, over the next 3 years, recompeting every single one of those. Some of them are on their 11th, 12th, 20th extension. And most of those, it's not something that HHS necessarily started or that we wanted to do. A lot of those started as community grants many years ago. And you're correct that it's the same job for just about the same amount of money for the past 15 years without a whole lot of looking at what they're doing. And so it makes it's a lot more difficult when it's non-competitive to, especially from existing or legacy community grants, to change that. So we're going to kind of forcibly make that happen by
I want to start
competing
with
these.
those first. We
Absolutely.
need to start with those first, and
Okay.
whether we're looking at the ones who have been in the budget for over 15 years, and then we need to start with those
Absolutely.
that have been in the budget the longest and continue to whittle down and evaluate what we're getting for our return on our investment, and are we truly meeting the needs of our residents. So I'm not sure where that is in the work plan, how we're going to get that done with 250 plus contracts, but if you all can get us some sort of plan how we're going to work through that, that would
Absolutely.
be helpful.
Yep.
Thank you.
Yeah, I'm going to try to keep us moving here because we still have to get through the various county agencies. It's a good point. It's not one we're going to solve in the next 6 weeks through the budget process, but Councilmember Sales has made this point before, and it's a very important one. And so I do think that as a follow-up to this year's budget process, let's get as much as we can through the next 6 weeks, but let's look at those contracts and, let's acknowledge these are some really important community-based organizations who are fitting a need, who would welcome the opportunity to rebid, and I think it is time for us to take a look at that. Councilmember Lukey.
Very briefly on this, because this was my ask at the close of last year's budget season when I was asked, what would you like to see moving forward? What would be helpful? I said, getting all the expired contracts redone and doing them in, multi-year increments, but that you had to have a consistent way of wrapping your head around who was doing what the county's ask was, because some of these have gone on for so long where they're in an expired posture, which would pain me if I was your attorney, right? That creates this bizarre tension that we have, which isn't good. Right, at the end of the day, DHHS wants the community served, these providers want the community served, but not everybody's on the same sheet of music about what the scope of the services are supposed to be, and then it's, I have a new idea, I need funding for it. But we might not be able to do that, right? And so it has to be, well, only if we've added an addendum or we include in there a process for how this will happen, because it's coming back and forth and it puts everybody in an unnecessary struggle, and everybody, our nonprofit providers deserve predictability. And you all need to know what services are scoped out that are going to be delivered. And so there needs to be a lot greater precision and cohesion here. And I think that will reduce headaches for you all inside DHHS, and it'll reduce headaches for our nonprofit providers as well, because I think there's a lot of anxiety every year about where am I now, because truthfully their contracts are in fact expired. And that's not a good place for anybody to be. So I am happy at any time to help out in any way I can post-budget season. Come get me after Memorial Day. But I am eager to assist with this because I really do believe that it would help the functionality of everything you all are doing and everything they all are doing. And it gives greater funding predictability to us and to them, and to know where we all need to stay. So thank you.
Thank you. All right, let's move on to the next item.
Finish with the overview section, so next would be the service area aging and disability.
Terrific.
So we'll proceed, okay? Everybody ready? Okay, so for aging and disability, there is a increase of $6 million for the budget for FY25 recommended, and an increase of 9 FTEs. Staff did want to note that this memo went to print prior to the public hearings, and so throughout this service area, we'll be bringing up the related testimony that we have received, and make sure that you all have copies of it as well to consider as you go over the recommended budget items. So as described, we have included a chart of the new and enhanced programs, shift or transfers between departments, those changes required by law, and potential reductions. So new and enhanced programs list 7 budget items that we will go over in detail, 1 required by law, and then there is 1 potential reduction. We start this service area talking about the vacancies. As of April 5th, there were 32 vacancies in A&D. 19 of these positions are new and never filled from previous years. If you recall, last year there was an ad of a lot of positions, 16 new positions in response to the End the Wait Act. Those positions are in support of the Medicaid long-term care programs, and there is an expectation of offsetting revenue once those positions are filled. So here you have the listing of the positions of the 32 total vacancies, and 20 of the 32 are in process. Only one of the positions, the Ombudsman Services and Area Agency, has been vacant for more than 1 year, and that person declined that offer. So the department is expecting all of the current vacancies to be filled before or during FY25.
Okay.
Okay. So just to note, multi-program adjustments. The multi-program adjustments are listed under the different program areas within the Aging and Disabilities budget section. This service area in particular had some unusually large adjustments. Under the administration section, there reflected the removal of a one-time lapse in FY24. Under the assessment and continuing care management services, there was a $1.2 million increase, and in the long-term care services, a $1.8 million adjustments. And DHHS share, they are primarily due to annualizations of new positions approved for FY24. So we did talk about these in the overview memo, but we just did want to call attention to those where, there's a significant amount of funding that really isn't tied to any specific program increase, but just for that service area.
Okay.
So as part of this process, council staff requested an update on some programs that serve residents that we tend to hear about just because there are changes or there's changes of the program, just different things that are going on that affect senior residents, and they express their concerns to either DHHS or County Council. The first is the nursing home inspections. DHHS used to do nursing home inspections. We were the only county, I believe, in the state of Maryland where we did our own inspections. I think around 2 years ago, the state shifted and took and did not renew the MOU and stated that they would do the inspections from now on as they do for all other counties. So the Commission on Aging and the department took an active role in responding to this, trying to understand what those changes mean, how will that impact our nursing homes here, how will we deal with complaints, because even though it's the state function, locally we hear about the complaints and want to address whatever those needs are that those residents are facing in those nursing homes. So right now, not much has changed. There was some advocacy. Senator Kramer introduced legislation requiring MDH to grant authority to local jurisdictions to conduct inspections. Right now, that legislation is still pending. The one thing to note is that once funding is provided, DHHS would have to recruit, hire, and train a qualified nursing team, and they would be located more within public health and under LNR, the License and Regulatory Division. And so A&D themselves cannot conduct inspections. The authority is granted by the local health per COMAR. So the state is still doing inspections. I believe A&D is still staying on top of things, and with the Commission on Aging in terms of understanding when the inspections are happening, if an inspection has been requested and hasn't been fulfilled, why hasn't that happened? So I think it's a bit of a challenge for the A&D right now.
I know both my colleagues want to make comments. I do as well. Dr. McGee, why don't you just give us your overview and perspective, and then we'll jump in.
Certainly. Good afternoon, everyone. Thank you so much for the overview, Tara. Patrice McGee, Chief of Aging and Disability Services. So Senate Bill 825 that Senator Kramer introduced did die in committee. We have had several conversations with the Maryland Department of Health, Office of Healthcare Quality regarding nursing home inspections and the lack of presence in Montgomery County. Both Dr. Bridgers and Dr. Davis and myself and several others met with MDH regarding this, as well as the Commission on Aging has met with MDH regarding this. From those meetings, we garnered that they are not interested in providing any funding directly to Montgomery County to do this work. They have cited that they are significantly understaffed and that the resources that they do have to service the entire state. Previously, when we had a team of 9 nurses within the LNR Division of Public Health Services, I think the budget was roughly around $1.5 million. So the state was giving $400,000 to the county to do that work. Since the MOU sunset in 2021, there has been little to no presence. Commission on Aging has been a stark advocate about the need for transparency when OHCQ is present. Our ombudsman team has had an uptick in the complexity of complaints that it's receiving, the length of time that it may take to resolve a complaint because, it's a team of advocates. They're not, my ombudsman team and our team of advocates, they are not inspectors. They don't have that authority. OHCQ has that authority. And so we did brief the county executive on what it would take to reinstate a team. We're potentially having conversations about a phase-in approach. Instead of trying to hire 9 nurses, hire a smaller team of 3 potentially and have a phase-in approach because 3 would be better than nothing at all, which is where we are right now. Again, very, very little presence. I think since 2021, OHCQ has conducted 1 annual survey, and that is unacceptable. So really having a conversation about what we can do from a local perspective to move things forward. Our intergovernmental relations is still having conversations with MDH to see if they would grant us that authority. So is there anything else to add, Dr. Bridgers?
No, thank you, Dr. McGee. We really looked into this, and more importantly, when we talk about those vacancies post-COVID, many of those nurses that we use were reassigned, and so that left a gap. And so as we continue to have conversations, we understand the need, but I, as the director, was not, and I briefed the county executive, as Dr. McGee said, I did not want to put the county at a fiscal risk by committing to the work. When the MOU lapsed in 2021, ARPA money was available and other state level funding was available. We no longer have those funds available. So from a county perspective, we didn't have the fiscal resources to do that. And I shared this with MDH and OHCQ and even with the state delegation for the county. And I wanted to state that to the committee this afternoon, that we've thought about multiple ways to approaching this, as Dr. McGee indicated, even having a smaller tiger team, if you will, to go out, because there is a need for that. But financially, the county will be at risk because we don't know about the level of effort. Suppose there's an outbreak, and even have a conversation with Dr. Davis and looking at some of those outbreaks in the long-term care facilities that we've traditionally mitigated through inspections. And so taking all of those variables into consideration, we wanted to present to council, as we presented to the county executive, a realistic approach to possibly resuming this work.
So I'll just jump in really quick. I know my colleagues do as well. This is the perfect negative storm. With the fastest growing demographic, one of the most vulnerable populations, at a time where story after story that's been printed in our newspapers about awful cases, some of which that have been brought to our attention by constituents, particularly during the pandemic, is pretty crazy. So I just want to clarify. So there's 2 issues here. One, obviously, is funding. But 2, it sounds like we need MDH and the state's approval and authority, even if we wanted to fund this initiative ourselves before we could fund it ourselves.
That is absolutely correct.
Okay.
OHCQ has to give us the authority to do the work.
Okay. First, credit to Senator Kramer, our friend and colleague, who tried to elevate this through the legislature this year. I'm disappointed and frankly frustrated to hear it didn't even get out of committee. I can't imagine that we're the only jurisdiction facing this issue. It's more acute here because it's the fastest growing demographic we have among our population. But needless to say, this has to be, and it sounds like it's a priority of the executive branch. I'm sure my colleagues and I will share it's a priority of ours as well. And so we have to aggressively look for solutions here immediately to be able to elevate this issue and frankly prevent future tragedies from potentially happening. I'll yield to Councilmember Lutke and then Councilmember Sales.
I don't want to think too much on the fly. That's dangerous and risky, but I have ideas, right, about how this can be done without having to wait till the next legislative session. And certainly via the MOU could be one mechanism, because the legislation as it was proposed and as it passed out of the Senate, 45-0, just is very simple. On request of a county, the Secretary of the Department of Health shall delegate to that county the authority to conduct the site visits and full surveys, right? That would otherwise belong with the state entity that does it. They don't have the people. You're telling me that they aren't planning on having more people, and they aren't going to increase their inspections, because right now they're required to come out and they are required to visit every nursing home once per year, and that is it. But when there are complaint-based issues, that they don't have the people to do the work that they are supposed to be doing.
So I will say they have made complaint visits. I think they're prioritizing the complaint visits. And this is just going off of memory. I can get exact figures, but I believe that we've had 3 complaints responded to when they are in Montgomery County and they touch down in a facility. They are there much longer than they originally anticipated. That's what our ombudsman team had been made aware of, whereas they think they may be in 1 or 2 days. They're actually in for 2 weeks because of the level of the complaint.
Right, I was going to say that's indicative of the issue.
Exactly.
Yeah.
Exactly.
Yeah, and what we don't want, and that's why I'm taking the time to do this, is to be heard loud and clear. We don't want to be ProPublica's next story in Montgomery County. And
Absolutely
we don't want to be ProPublica's next deep dive on nursing home issues story because the state of Maryland didn't get enough inspectors out here upon receipt of complaints. And they're recognizing and they have knowledge now that when they are coming, they're needing to spend more time because it's more complex. And so, to the extent that they're saying, we'll give you this authority via the MOU or by some other mechanism that doesn't involve a statutory change, we need to take care of that here. But the state should also, because it is the state's work that they're then delegating to us, and frankly, the state should be paying for that since it's work that they are already required to do. Thank you.
Yeah, and there's a lot of precedents. I mean, the local management boards, issue funding to jurisdictions for matters related to children, youth, and families, and so there's no reason, well, I'm sure there are reasons, but I can't imagine the very good ones for us not to be able to pursue this. Councilmember Sales.
Thank you. My colleagues have already mentioned some of the questions that I had. I just want to know how many nursing homes do we have here? And are these are nursing homes, long-term care facilities?
So the inspections that we're speaking to are in nursing home facilities.
Okay.
So our ombudsman team also visit assisted living facilities,
Yeah.
skilled nursing, group home, all of the facilities, right?
Okay.
And so when we're talking about the nursing home inspections, that's what we're speaking to, and I believe there's 36, but I can actually get that list to you as well.
Okay.
Yes. And just also point of clarification, because I mentioned 1 annual inspection, 3 complaints since 2021. When we met with MDH, they said that they have data showing that they've been in more facilities in Montgomery County and that they would share that with the Commission on Aging. We are still waiting on said list. So that 1 and 3 is what has been shared with our ombudsman team.
So they're supposed to visit once per year.
Correct.
Our 36 facilities, and they haven't provided that data to us yet.
You are absolutely
so
correct.
We need to make sure we get that data immediately. And do you know if we have any complaints outside of those 3 complaints that were shared?
No, so
from
that
those
is one of
36?
the issues, transparency. That is one of the issues that Commission on Aging has been escalating for quite some time. They are not sharing that level of detailed information with the public, right? And so I can guarantee that they have not made 36 inspections
Visits.
annually since 2021. We are aware of one. They have a understanding with the state ombudsman. They do let the state ombudsman know when they are coming to a specific jurisdiction, but her numbers aren't much higher than ours.
This is scary to imagine that since the pandemic, we have not had consistent visits with the places that are responsible for caring for our most vulnerable. So I'm sure my colleagues will be in agreement that we'll be asking some follow-up questions and requesting some data and accountability, because this is totally unacceptable.
Absolutely, I agree.
Yeah.
And once we receive that data that they promised to the Commission on Aging, I will make sure that's shared with this body.
We'll ask for it. And
Yes.
hopefully we'll get it faster than
Yeah.
the commission.
Yeah, and I think we need to leverage our contacts here in the governor's office. This is something we have to elevate. I'll just say, I'm going to state the obvious. People who are in extraordinary vulnerable populations may not be as likely to complain. And so if something rises to that level, then, it's a very serious issue, but there are probably many more. And the ombudsman spoke to this during COVID. And so it's something we got to follow up on. So, Ms. Clemens-Johnson, I think we'll want to elevate this as much as possible. We'll want to collaborate with the executive branch on reaching out to our partners in the governor's office immediately. And I don't know exactly what form that will take, but it's a priority.
Okay.
All right, let's move on.
And I'll just speak to the next session on which we requested an update on was the ombudsman program. I believe you guys just talked in detail about that, and the department just provided more information about the increase in nursing home complaints with the lack of the inspections that that now is falling on the ombudsman program to be much more engaged with the complaints that the residents are stating, and below it kind of just details the listing of issues. So we will use that information and also follow up as you stated, Chair. So the first item to consider for the budget is the continuing of the senior lunch program at Silver Spring Recreation Center of $147,875. So this is replacing federal funds that were one time and no longer available. Council staff recommends approval of this funding to continue the senior lunch program, and this will be added to that new and enhanced program category. We requested additional information about just the senior nutrition program in general, and they provided that detail, which is listed in your packet.
I know a lot about this program. I'll just note in surveys that have been done for a significant percentage of the seniors that participate, that is their primary meal of the day. And so it is critical that we keep this going. So I think without objection.
Okay. The next item is under Adult Protective Services. This is a requested enhancement to reduce wait lists for the Adult Protective Services case management section, $196,000 and 3 FTEs. So the department shared that this is says reduce the wait list, but DHHS provided the information that APS doesn't response is mandated and does not maintain a wait list. So this is just basically based on the demand that they're seeing within the program, especially since the End the Wait Act. So the 3 positions requested are a supervisory social worker and 2 social worker number 2s. DHHS provided the average caseload information, which is 45 cases per social worker. And there is more detail included here in your packet. Council staff recommendation is we did not provide a recommendation for this item. We just noted that there are currently 4 social worker positions in APS that are vacant, for which OHR recruitment is pending. The committee may want to hear from the department how it intends to get the currently approved new social workers position filled, and then fill an additional 3 positions that are proposed here for FY25. This would be added to the new enhanced program category if approved.
Councilmember Sales has a question or comment. Do you want to have Dr. McGee speak first, or do you want to
Well, this was on the last item for the senior meals. I just saw that there is a zero line item for Mid-County. So is that center no longer in operation, or have we discontinued meals there? It says Mid-County Tuesday or Thursday, zero.
That may be an error. I will check and
Thank you.
follow up on that.
Okay,
Great.
thank you.
Dr. McGee?
Yes. So, if I may, I want to start with the understanding of a wait list in adult protective services in APS. So, I think it's a difference of language being used internally and externally. So within the department, the service area, aging and disability service area, there are 3 divisions, one of being the case management services that's often referred to as APS care management, right? And so APS, yes, is a mandated service. We're responding to persons that are potentially in the crises. So that comes with a time frame, a mandated time frame that we have to respond to those investigation requests. You're shaking your head, Councilmember Luke. You are fully aware of that. What happens is we have an investigation team and a continuing care unit, right? So continuing care is actually something that we're going to be talking to the state about in regards to a best practice. That's not something that you see everywhere. And so what we have in our case management services division is we have, for demonstration purposes, we have APS, right, which is required, it is prioritized, and then you kind of have step down programs. So those investigations that are coming to us, those are individuals that are still at risk. They may not be experiencing abuse, neglect, self-neglect, or being financially exploited, but they still are at risk for institutionalization and potentially in some cases inappropriate institutionalization, excuse me. So with that, we have a host of other case management service programs that they may be eligible for or fit the criteria for to get those supports in order to remain in the community and be able to thrive in the least restrictive environment. And so what is happening, so with the level of APS investigation referrals that we receive, right, and that's being prioritized, those individuals are going to those step-down programs first. And what's happening is, as we get referrals for those step-down programs directly, that's where you're starting to see the wait list grow. And so with those individuals that are already at risk, sitting on a wait list, they didn't come in through APS, but they're sitting on a wait list. Now they've been on this wait list long enough where they're escalated to an APS situation. And it just keeps repeating itself. So there are wait lists in the case management service APS step down programs, but APS itself is mandated and cannot maintain a wait list. Okay, so that's one issue. The second issue that we're dealing with within this particular unit is that we had a contractor that pulled out of a contract at the top of the fiscal year. And throughout the tenure that they were in contract with us, they had staffing shortages, which is also something that we're seeing across many areas, as Councilmember Alvarez mentioned in the overview section. And with that, it creates a continuity of care issue because COMAR requires, with these programs, they require staffing ratios and certain staff be in place. And when those positions are vacant, we are then in violation of COMAR. And so because they pulled out of this contract, we have an existing infrastructure within Aging and Disability Services to provide these services. We were able to bring these clients back in-house to ensure their continuity of care. And as you've mentioned, these are frail, vulnerable adults, right? And so maintaining their level of service is critical for them to be able to thrive. So that's the other piece that we're dealing with and why we need this resource in this division. So those two things are working together. And then thirdly, you mentioned you wanted to understand our vacancies in this division. So we've mentioned, the majority of our vacancies within Aging and Disability Services and within HHS period are clinical in nature. So social workers and nurses, and there's a nationwide shortage, right? And so we've been experiencing that shortage. So we're working with human resources to develop creative solutions to address some of the challenges that we're seeing in getting social workers and nurses, but particularly for this for this particular service, APS social workers. So we've been doing some reclassing, some underfilling in our vacancy postings. We are working directly with university systems to get a pipeline of students into to social work, Masters of Social Work students to come and work in this division, as well as we have a collaboration that we are exploring with Children, Youth, and Families, Dear Treadvance and Oscar Mensa, really looking at a project that they've been working on with getting social workers into the CPS pipeline. And so we're looking to expand that across the lifespan, right? So just because someone turns 18, they come to Aging and Disability Services, right? So looking at that across the lifespan. So we're looking at creative solutions from that perspective. Right now, all of our vacancies in this division are in the HR process. Dr. Butchers mentioned I have started a 30-day pilot program with HR for 30 days to hire. So far, so good. It's working. And we're hoping that we can get the vacancies that we need with these creative solutions in that 30-day process. But I think it's also important to note, because Mr. Hodge mentioned this, we've had a lot of retirements in Aging and Disability Services. That's one of the key sticking points when I started. I was like, people are here for 20, 30 years. This is a great place to be, and it really is. And people have stayed with Aging and Disability Services for quite some time. So we're seeing a lot of people retire, and that's also a reason for a lot of our vacancies. So we are really working with, like I said, HR to figure out how we can fill these vacancies quickly.
Thank you. Just a couple of comments. So I think of all of those arguments, they're all compelling, but if we're out of compliance through COMAR, that, runs all sorts of risk and liability and exposure for the county as a whole. And obviously on the merits, if our caseloads are too high, it limits the ability of the case managers to be able to address the needs of the caseloads they have. And we're playing with fire there. With life or death consequences. So I personally support this recommendation for the 3 FTEs. I appreciate also the push for creatively filling these positions as quickly as possible. So you answered one of the questions that I was going to have, and it's not budget neutral, but this would, I assume, replace the contracted line item for the FTEs, or will we still have the contracting line item in addition to the FTEs? I'm just from a budget perspective.
So some of our services, because we see significant surges and increases, so APS being one of those, another one being our AIRS program, right? So we will have contractors. I don't think it will replace fully, but because I need to know what page you're looking at too for the number of contractors we have in that particular program. So it may replace some of the contractors, but at some point we may need a contractor because of the surge, right? Like our ombudsman program, we keep contractors in that program because of surge. So it's one of those things we kind of backfill with contractors.
Gotcha.
Yes.
I'm more candidly, when we have to go through and explain this to colleagues and again go through that very compelling list of everything's really important, anything we can do to strengthen the argument of a specific line item will be helpful. But in this instance, again, I'll say it one last time, if we're out of regulation, that's almost end of story. Any other questions or comments on this, colleagues?
Well, I just had a quick question. I think in the notes it said there are people on the wait list for services, 143 people waiting. Adult Protective Services?
183 individuals on the wait list. And these are the step-down programs that I was speaking to.
So what sort of services are these case managers doing? What's like, how would someone be referred and find themselves on a wait list?
And so clients come into services 2 different ways. Like I said, either through APS investigation, or they're being referred directly to one of the programs being social services to adults or senior care, or one of those case management programs where it's going to provide in-home assistance for like activities of daily living and so on and so forth, based on what that level of need is, right? And so those are the two ways that people are coming into services.
So is it a family member that's referring them to the county, or is it the agency?
Yes,
or
we
are they
get referrals from multiple
self-referring?
sources.
Okay.
Yes, so
Okay.
hospitals, so on and so forth. So we get we have multiple referral sources. And so where the wait list is being created again is because we prioritize, and we have to prioritize APS, right? That is our mandate. And so when those individuals are being prioritized, they're pushing others sort of down
So
the
what
list.
sort
that are
of
coming into that
services?
direct service.
Yeah, so what are they waiting for?
They're waiting for one of the programs. Like I said, social services to adults. May it be home care, right? May it be senior care, one of those step down programs that they are deemed eligible for based on their level of need. And some of those services could include like a home health aide, right? Someone that could help with light chore, someone that could help with activities of daily living, transferring, toileting, those types of things that they would have,
Okay.
those services that they would have in home to keep them in their home.
And so one social worker is managing 45 different individuals in all of those services.
Correct.
On a weekly, daily.
So those are
Annual
also on an
basis.
annual. Those come up for annual reviews as well, right? And so they are, the level of needs change as
Yeah.
people age and they're on these programs. So the level of need changes. So they are constantly looking at those plans for services, working with RSA agencies, residential service agencies. We use a lot of acronyms. Making sure that their level of care is being met. So that's what the social workers, the case manager is working on. And yes, best practice is 45 caseload.
Okay. And is that the normal
That's what
patient rate? Is that the normal ratio for social worker to client?
That is what they deem as best practice. Yes.
Okay.
Anything above that would not, you wouldn't be able to give the level of care that's needed to these cases.
Okay. All right. I'm glad that we are moving forward to fill those positions. Thank
So
you.
without objection, we'll go with the county executive's recommendation here.
Thank you.
All right, our next item is the increased cost, a 3% increase to the adult medical daycare provider supplement for $64,743. As the county executive has recommended a 3% increase for the support payments for eligible adult medical daycare providers. This 3% is consistent with the recommendation of support payments to the developmental disabled and to the nonprofit contracts. So the county has provided support funding for the adult medical daycare since FY19, recognizing the state's Medicaid reimbursement rate made it difficult to cover costs, including the minimum wage that are higher than some other parts of the state. In your packet is a listing of the appropriation that has been given annually since FY21, and FY25's recommended amount would be $2,222,848,000. In response to questions from council staff, DHHS shared that the current medical daily rate for the adult medical daycare providers is $113.19. The FY23 rate was $104. The state increase has helped to shorten the minimum wage gap and retain staff. And this, in the FY25 state budget, there is a proposed 3% increase in the daily rate that the providers would receive. We also want to note that there are two new organizations in the county. The FY25 recommendation was not adjusted for any costs associated with those new providers. So staff's recommendation is for approval of the county executive's 3%, but we did want to note that we received testimony from the Maryland Adult Medical Daycare Services. We sent around an addendum today. It is updated to the website for the public to view. The MADs, I'll just call them, provided like two recommendations. One was to recognize the two centers and provide a supplement for them of $200,144 to, I guess if you want to say right size them as part of the groups. of the adult medical daycare providers. And a secondary request is to increase the total funding overall above what the executive has recommended. Their total funding request would be $3 million. So with the amount that they're recommending, and the amount for the 200 for the new two centers of 200 and 144, this would be an additional $786,000 added to what the CE has recommended. So council staff suggests that if the committee would like to vote above and beyond or consider above and beyond the recommended 3%, staff can bring back this item and follow up and provide provide the details of increases, what those would look like at the level funding, what it would look like adding the two new centers, and then also give some percentage increases based on what the MATS has provided us. And so we can just provide a few more options for the committee to consider if you want to go above and beyond the 3% for the 29th.
So I'll just speak for myself really briefly. So state the obvious, Adult Medical Day is a wonderful initiative and program. It's a critical part of the solution to addressing the needs of, I'll say probably more times, our fastest growing demographic. And we're fortunate to have extraordinary providers who in many cases are providing uniquely culturally competent care and language access that is really important. It's moving the needle. Speaking for myself, I very much appreciate the executive's recommendation, and I appreciate the council's suggestion of us potentially teasing out. But we have to acknowledge these are, extraordinarily challenging fiscal times. Any increase, I think, is a positive, and I would like to know more about these two new organizations. I know a lot about the existing ones that are part of the network before I would feel confident and comfortable. And we have a year to get to know them, and so I think maybe we target FY26 to annualize and add them to the overall pie. That's where I'm at, but I will yield to colleagues. Councilmember Lukey.
Thank you. I just had, I echo Councilmember Albernoz's comments, but I did have one question because it's not clear from the way it's listed in the packet, the money that you put aside for consideration related to the two new providers. It wasn't clear whether that was assuming the 3% recommendation of the county executive or whether it was assuming 6%, which is the additional funds that these folks were seeking above and beyond the county executive's budget. So when you bring anything back to us, can you clarify that at that time?
Sure.
Thank you.
Councilmember Sales.
So it's the adult medical daycare is one of the new two, or?
The council,
The two new ones.
yeah, there's two new providers.
Yes.
So I believe there's 17 providers, maybe 17 providers that are recipient of the funds, and so there are two new providers that are requesting to be a part of those.
And how many people are they serving?
We don't. So we just got this information this morning, and so that's why we're saying we could tease out the details and make sure that we can provide you an adequate analysis of their request and what potential funding could look like.
Yeah, before I can make that decision, I would want to learn more about the population that they're serving so we can make a more informed decision. Thank you.
That's a very valid point. So we have a few more weeks before we wrap up our committee recommendations. So maybe let's put a pause on this one, and we'll come back and revisit it.
Okay, so we will move to the next section, which is the developmental disability provider supplement. Our council staff's recommendation is the same, but I will go over the highlights of this section. That the county executive is recommending a 3% increase to the support payments for eligible organizations serving the developmentally disabled. These community-based organizations provide a range of services to the adults with developmental disabilities. As the adult medical daycare recipients, they receive state funds, but they have not been adequate to support the provider organizations with the higher cost of business in Montgomery County. The county has provided this supplemental supplement to the organizations for around 40 years. So here, the FY25 recommendation is $21.6 million, an increase of $631,000 for FY25. Most of the organizations are in the process of moving to this reimbursement rate structure and requirements for the long-term services and support system. That change has been in process for several years. So the DDA has set a deadline for all providers to fully transition to that system in September 2024. So we will see what that looks like in the next fiscal year. So our recommendation is the same. We received an additional recommendation from Interact requesting a 4.5% increase to the DD supplement rather than a 3% increase. And so the Interact calculated this based on the Social Security cost of living, and the 1.3% increase reflects the increase in county residents served by the 41 provider organizations. This is an additional $315,000 on top of the CE recommended amount.
Thank you. State the obvious here, and we have a provider in the audience. The work of these organizations is extraordinarily important, and it's not something that the county government would be able to provide on its own. It's very clear that we would not ever be in the business of being able to provide the level of care that these organizations do, and that's why it was so important for the county to step up and provide this supplemental uniquely so many years ago, and I'm proud that we've been able to increase it year over year. And pretty significantly since FY21, acknowledging the growing needs. I know that the 3% compelling cases have been made that it's not keeping with rates of inflation, it's not keeping with staffing needs overall. This, of course, is a challenging circumstance as it relates to the budget, and I'm hopeful that the DDA debacle finally clears the way for there to be some necessary and needed support for these organizations. I'm not prepared to move something at the moment on top of the 3%, but this is, and it always is, something that we revisit on an annual basis, and we have made course corrections within fiscal years in the past, and we remain open to doing so. But at this point, I think the executive's recommendation for an additional $631,000 is an important one. But I yield to colleagues to make any additional comments or questions. Councilmember Sales, Councilmember Lukey. Okay. Ms. Clemens Johnson.
Okay. I do want to be clear about the recommendation for the adult medical daycare is that it is recommended approval of the county executive's recommendation, and that we will come back with the options for additional funding outside of that.
Great.
Okay. So the next item is the home care services. Increase home care services to meet demand and to serve clients experience homelessness. The requested amount is $160,957 and 1 FTE. This recommendation will allow DHHS to provide home care services to clients who are currently unhoused and those who have been recently housed through a program and services to end and prevent homelessness. DHHS estimates that there are approximately 40 to 45 clients experiencing homelessness in need of home care services who could be served. So DHHS shared that the position requested is intended to be held within the home care program, so not within SEF, but it will provide services in partnership with the Healthcare for the Homeless program. The requested position would perform certain duties for adults who are experienced or at risk of homelessness that are served by either APS or SEF. So the council staff recommendation is to add this to the potential list of reductions, excuse me. Healthcare for the Homeless has identified this as a need for several years, but it is a new program, and how it expands to home care services to this target population. If the HHS committee believes that reductions need to be identified in DHHS, and this would be starting a new program, that this would be one that could potentially be put up for reduction.
Dr. McGee?
Yes, thank you so much. So, just to hit on a few points here. One, we've talked, I know, in several meetings regarding integration within HHS. This would be that. So yes, the healthcare for the homeless has provided primary care and medical respite in the facility, in the shelter settings over the years. But what is lacking is an entity that's being able to provide activities of daily living, ADLs, for persons that we're seeing in the shelter setting. So within Aging and Disability Services, we already have an existing infrastructure for this work within our home care program. And so it's important to point out that the Older Americans Act defines older adult as a person that's 60 and older. So when you're experiencing chronic homelessness, you could be chronologically age 40, but your physical, your somatic health is actually 70 plus because of the chronic homelessness. And so we've had an uptick of persons in that range, right, between 40 and up, in the shelter setting that is in need of additional supports to be in the shelter setting. And staff within Services to End and Prevent Homelessness, we've had several meetings regarding some of these individuals that they're seeing and have been seeing over the years within the shelter setting to figure out how we can give them supports. But again, the current infrastructure does not support being able to provide services to those individuals. So this particular new program, project, pilot, however you want to frame it, would give that service in the shelter setting. It would allow individuals to stay and seek shelter in the shelter setting, because then we could come in and assist with those ADLs that are so needed for them to be able to be in that setting. And so that's the goal of this program, is so that we can build services for a population that's not currently receiving anything and needs the support.
You make a compelling argument, Dr. McGee. I do concur with the staff recommendation on this, just given the myriad of challenges and the juggling that we've got to do here. It is something that we should probably revisit and come back to over the course of the year, and hear more from the folks that are on the ground, and to provide more specific examples. And also, candidly, I'm just not confident that one position will be able to achieve all that you would like for it to achieve. It would put us in a better position than we are now, no question. But I also wonder if there's also a systemic approach that we should be exploring too, to this problem. But it's, until you mentioned it, I've thought about it, I've understood it, but you've acutely brought it to our attention. So I would like to follow up on this, Ms. Clemens-Johnson, after the budget process is over, when we get an update. Mm-hmm. Yes.
If I could add just one more piece to that, and so it is a phase-in approach.
Mm-hmm.
You're absolutely correct. So it would be one staff that would go out and provide services in those most critical situations, is what we're kind of looking to do. And Seth could provide the data that we've been looking at, and how we came up with this ask. So it would be a phase-in approach to grow the program over time.
Okay. So without objection, I concur with the staff recommendation. Yep. Okay.
Okay. So next is the Medicaid funded long-term care services for the Community First Choice Monitoring Program, $179,800,000. As we discussed in the HHS committee in FY24, this is a state-mandated program, and expenditures are offset by Medicaid revenues. So this funding would support the current contract, which is needing nurse monitoring billing hours, and the increases related to state rate increases. Council staff recommends approval of this item.
Okay. Without objection.
Okay. The next item is increased services to meet increased demand for coordination of community services program, $62,826 and 1 FTE. This recommended position is a program specialist 2. The position will provide service coordination, case management services to individuals who have been determined eligible by the DDA coordinators to bill for services, so there will be offsetting revenue. We recommend approval and cited the data earlier in the DD supplement section.
Yeah, this represents an opportunity cost. I concur with the staff recommendation, so without objection.
Okay. And the last item for the aging and disability is increased costs, the respite care for $112.45 and 0 FTEs. So the total recommended FY20 budget for respite care is $1.626 million. The additional funding is about a 7% increase. The county staff did recommend approval. The funding is needed to stay at the same services, and the same service is not sufficient to accommodate all the requests. However, if the committee recommends approval, this would be included in the new and enhanced program category.
Councilmember Sales.
Thank you. I'm just trying to understand, it says 112,000 for 0 full-time employees. So who is this money going to?
So this money is actually going to expand the service, keep the level of services that families are currently receiving through this program. So respite care is a service that crosses several programs within aging and disability services. It's temporary relief for caregivers. And so if we were not granted this funding, we would have to serve 24 less families through that program, because we wouldn't have the funds to provide the service. So the funding is going into the program itself to be able to provide the service to families.
So it's not going to staff to provide more services?
No.
So what is it providing exactly?
So we contract with an organization to provide the respite services. We fund the amount needed in order to pay the individuals that are providing the respite care. So these dollars would fold back into the program. They would increase our capacity in the program.
Okay. So the CNAs aren't getting more money?
So it may not be a CNA that's providing the service. It could be, but it also could be someone outside of the family identified to provide the temporary relief for the caregiver.
Okay.
And so they would be, these funds are going toward their payment for the service.
Okay.
Yes.
Okay. All right. Thank you.
And I just want to be accurate. So this would be maintenance of the current service levels to receive this, and if this wasn't added, there would be a reduction of service?
Correct.
Okay.
I think without objection. Yeah.
It's this section.
All right. Thank you, Dr. McGee. So we're on to behavioral health services. Dr. Santiago. I would say welcome, but you've been sitting there the whole time.
Good afternoon. Patiently.
Welcome, Ms. Yao. Ms. Yao, I'll turn it over to you. I'll give you a second to get adjusted. While we're waiting, Dr. Santiago, any opening comments, brief? Or actually, why don't we let folks why don't we take a 2-minute recess? We've been going for 2 hours, and we'll be back. All right, let's get started. Ms. Yao.
Okay, so for fiscal year '25, the executive is recommending $61.8 million for behavioral health and crisis services. It's about $8.5 million increase, or 15.9% from the fiscal year '24 level. There's a proposed increase of 17.2 FTEs. The tables on page 2 going on to page 3 of your packet describes the programs in the service area and their approved 24 and recommended 25 budgets and FTEs. The table at the bottom of page 3 includes the recommended changes that would go on the new and enhanced programs list. We'll be reviewing them. The two are related to the funding that's replacing grant funding, so it's tax-supported funding for the MCOT teams that were added with a federal grant. So the $1,230,378 is the first part of the total $1.4 million, and then there's also an increase in capacity, adding 2 MCOT teams from 5 to 7, and that is a cost of $252,972. The annualized costs for these for the personnel costs are $1.5 million for the existing teams, and then $429,000 for if we add 2 additional teams. And so the total annualized cost for staffing for the MCOTs is $1.9 million. There is a description of how these teams are deployed. Currently, they have teams in Rockville, Silver Spring, and Germantown that operate between 7 a.m. to 3:30, and then also 3 p.m. to 11:30, as well as 11 to 7. There are 2 staff assigned to the MCOT for those periods of time, not at each of those locations. So council staff recommends adding 2 tranches of funding to the new and enhanced program list, representing those 2 amounts, what it takes for continuing 5 teams, and then additional funding for adding 2 additional teams to that complement.
Thank you, and thank you very much for the packet, Ms. Yao. Great job as always. Dr. Santiago, did you want to make any opening comments? You gotta hit your button.
I'm, the best way to express it is I'm delighted that we're able to expand at the mobile crisis teams at the crisis center, and the activities that they're doing, the numbers of people that they're serving. About I think the latest count was like 2,200 a year. Which is pretty admirable. With our new peer support specialists that have been added since 2022, they're doing terrific work. They're increasing their involvement with the MCOTs. I can go on and on. I can say also we're in the next couple of weeks, I expect police officers are going to integrate also at the crisis center, which will provide support. We're getting funding from Tacoma Park for a team there, and we're hiring. I think we have 1 person already hired for that position. So it's all good news for Montgomery County and for the crisis center. I'm delighted to support this budget this year, and hope for your support as well.
I certainly will. I know the only question is, could we add more, and we can't. From my perspective, I think we need to continue to evaluate this program as we, continue to phase it in. I know that it's an iterative process. We're learning a lot in real time, and we are applying what we've learned to strengthen the program. Clearly, the needs are significant and obviously growing, but this is. We've had several sessions talking about the importance of this model as a whole, and I once again want to publicly thank Councilmember Lukey for looking at codifying this in law, and that's an ongoing conversation to see how best we can address this very pressing need and the best solution to get us there. But needless to say, it starts with funding the program. So I concur with the executive recommendation, and I also concur with the staff recommendation on the tranches. And Councilmember Sales.
I'm trying to understand the general fund expenditures of 53 million, and that's encompassing how many different programs and nonprofits? Were those previously state and federally funded programs? Like,
I'm not looking at the budget right now, but 53 million is a fiscal year 24 or the fiscal year 25?
well, it looks like the county executive recommended 61 million.
Correct. That's what I understand.
Oh, okay. Yeah, so there's a 16% increase. But these are coming from general funds and not operating funds. So these are in addition to the budget?
They're also grant, so it's the entire budget that for BHCS, which
And it's
would be
all
grant-funded. It comes from the state, it comes from federal sources, general funds. Yep.
Oh, so who is this? How many nonprofits is this going to?
We can follow up with you with specific information about the types of nonprofits that have contracts with behavioral health and a breakdown of the budget by funding source. I'm happy to provide that information in a nice written document.
That would be helpful.
Okay.
Okay.
Yeah, I'm very happy to do that.
Thank you.
Great. Ms. Yao?
Okay, the next item is the 988 crisis hotline. There are two adjustments for that. One is an increase in grant funds of 1.3 million, and there's a corresponding decrease in general funds of $320,298. So the table on page 5 of your packet breaks out the general and grant funds supporting this program from fiscal year 24 to fiscal year 25. It looks like, based on this breakout, that there is an increase in funding overall of 1.3 million. Certainly, every mine had requested the county to provide level funding for their service, which was 2.2 million in local tax-funded dollars. Council staff had a question again. Sometimes what's showing in the in the budget book related to grant funding has sometimes timing issues. So we understood that the executive had intended to level fund this program, but hadn't gotten an explanation of, what these amounts mean before we published the packet. So council staff does recommend approving these amounts, or at least seeking clarification that the total recommended budget is level funding, and if not, if there's ways to actually reduce general fund to provide that, to move forward with that, but seeking clarification about what is being made available to every mine.
Councilmember Lukey.
Yeah, I think, the way I'm looking at the chart, I'm going, the grant funds in FY25 look like they went way up, but I don't know if those are in progress, if they are intended to be received by a certain date. And, at the end of the day, the goal is we do have to level fund the 988 operations. We have to fund that, right? The question is how much and where is it coming from? And it sounds like that's still a bit of a question mark. And so I appreciate that we will come back to that once there's greater clarity. But certainly we recognize the importance of our 988 local jurisdiction service provider.
Does executive staff have a response to that right now?
Well, like you implied, Vivian, the largest increase was from the state. So the state is providing significant funding for them. I think it's close to level funding with respect to general funds. If you look at the chart, it's very, very similar numbers. But yeah, the increases are primarily from the state. And you may know that the 988 bill in the Maryland legislature passed. So that's going to bring even additional funding. I think there was a rate increase on internet, I believe, that was approved. So there's going to be more revenue in support of 988. But that's a future.
Well, and just for clarification, since you raised this, are the grant funds that are showing here, is that anticipated because it's in the state's budget that funding is coming to you starting FY25, meaning July 1st of this year?
That's what we understand has been committed for fiscal year 25.
Okay. Thank you. And then, and then overall, we have a net decrease in taxpayer-supported general funds being allocated for the FY25 budget.
That's what the recommended budget suggests. Yeah, thank you.
We'll provide more specific information about the funding strategy for this with exact details on the revenue sources.
Great. Councilmember Sales?
Thank you, Mr. Chair.
Councilmember Albanos and the council. I made a note, would it be beneficial to the council when there are general fund expenditures to look at those specific grants by name categorically so you can see the breakdown and the use expenditures? Because I have notes that there were several questions that came up regarding that, so I asked OMB and the staff to work with us to provide those numbers so that we can have them available during upcoming sessions.
Great. Councilmember Sales.
Yes, I see that we've lost the funding for the SAMHSA grant. Do we have any other grant opportunities we're exploring in the pipeline that we are thinking about applying to, hoping to apply to replenish those funds?
Yeah, the one that is referred to here, it was, Grace can probably explain it a little better than I can, but it was eliminated. It's going to go away on August 31st. However, the recommended budget then suggests a smaller amount in the budget. So it's not completely, we're going to be able to sustain 12 positions related to that grant.
The $1.6 million grant?
Yes, correct. I think the sustained amount is, 1.2, 1.3, 1.2.
We could provide an exact breakout. So basically, in fiscal 24, there is grant funding for these positions, which the fiscal year and the grant term don't exactly line up. So there's a small amount of funding for about 2 months of the grant term within fiscal 25. So there would be an annualization cost in fiscal 26, reflecting all of the positions billed to the general fund in fiscal 26. I believe your question was about grant opportunities in the future. My understanding is that the SAMHSA grant was a one-time grant.
Yeah.
I'm not sure if HHS is aware of other grant opportunities, but
yes,
I know
we
that
are pursuing other grant opportunities, not only for our mobile crisis outreach team, but across HHS as part of our internal assessment based on our fiscal needs. So it's not just the SAMHSA grants, it's any HHS related grants at the federal level, but even at the state level. So we're looking at multiple funding resources, which is part of our strategic plan to look at those touch points that we can follow up proactively to get additional dollars that may not be covered in general funds or other grant-based initiatives.
Yeah, because I would hate to launch this program and then not have sustainability and having to keep dipping into our general funds.
Yeah. And I should add that the state provided us with $1.1 million in fiscal year 24 for half of that money for additional MCUT staff. So we're grateful to the state, and apparently the state is interested in building on that contribution in fiscal year 25.
Is that included in this packet?
No, I don't think it's included in this packet, but we're grateful for the state grant.
I would love to see that in writing to make sure that that's resources, those resources can be depended on annually. So I love a hope and look forward to learning more.
All right.
The next item is another grant that we received. Again, this is coming from the Opioid Abatement Initiative. It's $1.563 million in grant funding, which will analyze the initiative that was approved by Council on February 27th. It will support strategic initiatives focused on substance use disorder, peer support, and treatment for youth with substance use disorders. There is an update on where things are in your packet. I don't know if you want to hear from the department about that, but otherwise, council staff recommends approval of this adjustment as submitted.
I'll approve the staff recommendation, but why don't we get that update?
Yeah, again, we're grateful to the state for their work on these settlements with pharmaceuticals.
Nice.
Over the next 18 years, we $43 million are being allocated to Montgomery County. The $1.5 million is a conservative estimate of what we should receive. I think it's a fiscally responsible estimate because we may not know year by year, but the estimate in terms of the settlements themselves over 18 years is for $43 million over 18 years. So we're grateful. And of course, I'm grateful for this council that approved on February 27 the first $3.1 million in the special appropriation for fiscal year 24. And you were able to see the plans at that time for the funds, and we're implementing right now. And if we had time, I could go into more details of what we're doing, but I'm not sure this is a time to go into all those details.
Why don't we follow up? That sounds exciting, though. I'm glad to hear you're all making excellent progress, and clearly this is a great area, and appreciate the partnership with the state. That's important. Councilmember Sales.
And so it says 3 organizations are going to receive these funds. Are you able to tell us quickly who those organizations are and how we are providing those, I guess, what the work order is going to be in oversight for these funds?
Yeah. I'm being advised that I should not disclose yet. Maybe it's because the letters haven't been sent to them. I know who they are, but I prefer not to disclose.
We can talk after this as well. Thank you.
I'll whisper in your ear.
Nice. Awesome. So great. All right.
I have a quick question.
Yeah, Councilmember Lukey.
But I hope nobody's kicking you under the table, Dr. Santiago. Yeah, all the hands were on the table. So just a quick question, because our offices had all received some questions about this, and this may be to the earlier point, talking about the 30-day program, hiring program, and the work that Oscar's group is doing within Department of Social Services. But the Treehouse Child Advocacy Center, we had some outreach there about the forensic interviewer position being eliminated.
That actually will be taken up when we go over the Children, Youth, and Families budget. So it's not in behavioral health and crisis services.
Okay. Then I will just know that'll come back. Yes, there you go. All right, thank you.
Anticipating that.
Thank you.
Okay, so the next thing is multi-program adjustments, which includes compensation changes, benefit changes, staff turnover, reorganization, and other changes that affect multiple programs. Except for 24-hour crisis center and administration, behavioral health and crisis services, the only recommended adjustments in the other programs are multi-program adjustments. And so the table on page 7 of your packet breaks them out and explains, where the multi-program adjustment is greater than 10%, the reasons why, and if there are changes in FTEs, it includes that as well. Behavioral health and crisis services includes some shifting FTEs to meet operational needs. So you're seeing FTEs in different places, and that accounts for some of the larger amounts in there, as well as annualization and those changes which were discussed in the HHS overview. So those would not be reviewed in this service area right now. Okay, and the last thing is a vacancies update. Basically, the service area has 41 vacancies, 10 of which are new positions. So if you take out the new positions, the number of vacancies, 31, is comparable to what they had last year. There are 5 positions that have been vacant over a year: a psychiatrist, 2 therapists, office services coordinator, and client assistant specialist. Over half of the vacancies, though, are in the 24 Hours Crisis Center program. And there is an update again on what the department is doing to address that, those vacancies, which includes recruiting social worker students, using Therapist Ones at the Crisis Center, internships that could lead to moving to merit positions, hiring peer support specialists, when hiring therapists may be challenging. So, and the department has been managing these vacancies by increasing overtime and using peer support specialists where possible.
Dr. Bridgers, did you want to elaborate? I think this sort of speaks for itself and is consistent with the other practices in partnership with the Office of Human Resources, but anything you'd like to add?
Sure, absolutely, Councilmember Alvarez. Just to restate, we're looking at alternative strategies to recruit. We're, in our behavioral health and crisis service area, we look internally and externally. We understand that this is a complex and challenging service area dealing with the many mental health concerns in the community, but not only for the community, but for our staff as well. We have to think about the wellness of our staff. And so part of that goes into our recruitment strategy, because folks realistically suffer from burnout. Working 24 hours, this isn't shift work. So we need to look at the humanistic, person-centered approach internally as we practice it externally. And so we've done that. We continue to do that. Our staff, Dr. Santiago, we meet more than once a week to talk about not only the program needs, but our staffing needs. And our staff show up every time, in every situation, to do the work that's much needed in the community. And it is a challenge. It's a complex challenge, recruiting challenge, and handling the vacancies. I can't tell you how many texts I send to Mr. Hodge at 12:30 at night or 5 o'clock in the morning about resource needs. And so I wanted this committee to understand the nuances and the challenges that we face in hiring across the area. And they are individual challenges across every area, because the challenges that we have in behavioral health aren't those challenges that we see in public health. But across the agency, they are specific to those clinicians and those social workers and those nurses that we need. So I wanted to just share with that, just to add or enhance some of the complexities that we have, complexities of the vacancies within HHS. And thanks, Ms. Yao, for putting together and making all the edits, because we sent her several pages and she was able to pare it down just to a couple of parenthetical expressions of our thoughts.
Mr. Hodge?
Just to be clear, I answer all of those text messages as they're sent. So, one good news item, we out of the blue just had a psychiatrist who applied for that position. So that's a good news item. But we've also been looking at, and this has been a couple of years in the making, about using psychiatric nurse practitioners in the absence of psychiatrists. So we're looking at ways to fill those positions, meet the needs in a variety of ways.
Great. Thank you. Ms. Yao?
That's it for behavioral health and crisis services.
Wonderful. Thank you all. Some follow-up items, but thank you all so much.
We also now have
Yes.
the work session for Executive Regulation 3-24.
Yep.
Crime Victim Compensation Fund alterations. So on March 28th, the executive transmitted this proposed regulation to council. The proposed regulation was advertised in the February County Register with a comment deadline of the end of February, and no comments were received during that comment period. The council is reviewing this regulation under Method 2, which allows the regulation to take effect if the council does not approve or disapprove it within 60 days after receiving it. The memo transmitting the regulation is attached at Circle 1. The proposed regulation is attached at Circles 2 to 7, and the draft approval resolution is attached at Circle 11 to 12 of your packet. The Compensation Fund provides financial relief to victims of crime committed in Montgomery County or a resident of Montgomery County who is a victim of a crime in another jurisdiction where comparable compensation is not available. The proposed regulation amends the existing regulation as follows. It increases the total maximum compensation per single incident from $2,500 to $5,000, and then adjusts various maximum compensations, various reimbursements that are linked as a total percentage of maximum compensation. So that would be mental health services to the victim's immediate family or household members that qualify for income eligible families, and so that is 20% of the total maximum compensation. So that increases to $1,000. Also, for mental health services for when the director waives income limits for families, that is going to be 10% of maximum compensation, so that would then rise to $500. And also increased compensation for victims where the director has waived income limits, and that again is 10% of the total maximum compensation of which would end up being $500. The compensation for mental health services for victims' immediate family are not included in the victim's total maximum compensation per single criminal incident. There is also another provision that makes funeral, cremation, or other burial and final disposition services for the victim eligible for reimbursement, and also allows funeral, cremation, or other burial and final disposition service providers or other persons with proper documentation of payment to request and receive compensation for services provided on behalf of the victim. The HHS committee has heard from the Victim Services Advisory Board on a number of occasions about the need to increase this compensation. The amount available per criminal incident has been capped at $2,500 since 1988. And so this increase is needed to better support crime victims who incur financial losses, including medical bills, lost wages, funeral expenses, etc. The fiscal impact statement for the bill is included in your packet at Circles 8 to 10. Because the amendment doubles the compensation available for each category of payee, the statement assumes that the compensation distribution under the program will be twice the fiscal year 23 levels, resulting in a total increase of $43,000. The information from the executive does suggest that the number of individuals that may request compensation under the increased limits and the number of final disposition providers who will request compensation is uncertain and certainly will affect the total amount of program expenditures. Council staff does recommend approving the executive recommendation as these changes are needed to better support crime victims, but I didn't get a response in terms of what was the actual budget for the fund in fiscal year 25. So the committee may be interested in hearing that, and also asking how does the executive handle instances when there's greater demand for this compensation than what is actually in the budget.
Yeah, well, first I want to really acknowledge and thank the Victim Services Advisory Board. They testify before this body every year, and they have been bringing this up all 6 years that I have been serving as chair of this committee. So I was very pleased to see and appreciative of the executive's acknowledgement of the need for us to expand what is a lifeline for too many of the victims of crime in our community. And while it's still a drop in the bucket as compared to the social and emotional strain that the victims are, going through, every little bit helps. But I want to give the executive branch the opportunity to respond to Mrs. Yao's questions regarding demand,
Yeah.
overall budget, mechanics, that sort of thing.
Sure, and if you all don't mind, I'd like to ask Rosalia Scottman, she's the Director of Victims Services, if she can join us, because she can give you the whole meaning of this compensation, what it means for victims.
Great. Welcome. Thank you.
So feel free to ask her questions. You can start by answering Vivian's question.
So your first. Oh, Rosalia Scottman. I am the manager for trauma services. Excuse me, I am getting a little under the weather, so I apologize. I provide oversight to Trauma Services, which is a program that serves survivors of domestic violence and general crime victims of sexual assault, rape, homicide, bullying, all that sorts, and et cetera. Part of our program, we do have a victim compensation fund that we are able to provide as a resource to our many victims of crime. These funds are a great support to a lot of our clients. A lot of clients that we serve are the underserved population, very vulnerable population, no income, low income. So this is a service that's very vital for them and to them. So to answer your question, I don't know what the budget.
Right. I don't know if.
We can follow up with a specific budget number.
Okay. Yeah, we do have those numbers, so it's they're available, and how they work. We'll be happy to supply that information.
Councilmember Lukey.
I'm assuming that this is non-lapsing funding, right? So whatever fund goes in, money goes in, it's there. So you may have variability year to year. It's not going to necessarily be flat over time, and then it is available for the next year along with whatever else is allocated into that. And so my question relates, thank you all for updating, or the executive branch for updating the regulation, since it clearly had not been dusted off for a long time and needed it. I do note that there were changes to the state law as well that just well, here we are. It's the same week that this all ended. So the Victim Compensation Reform Act of 2024, which also provides funding for victims for similar types of things as well, and is a state-run program. The Criminal Injuries Compensation Fund, et cetera. So, and I know that they did increase dollar amounts. They updated those in the state law as well to kind of better match current times. My question is there anything, and it may not be that anybody has looked at it yet since the regulation went through the regulatory process, but is there anything that might need to be tweaked or adapted based on this new law at the state level, or adapting definitions, like they expanded the definition of a dependent, for example, and are we going to have parity with the state's definition of dependent?
Yeah, I think you're familiar how both work, so
Yes.
go ahead and
So
explain.
we will be updating
Okay.
the same, because we work in conjunction
With them.
the CICB.
Yep.
Yes.
Great. Thank you so much.
Councilmember Sales.
Thank you for that. And so do we spend the full $43,000 every year? Is there any carryover, or it's fully expended?
The 43,000 was the previous fiscal year's actual expenditures. That wasn't the budget. I believe the fund was underspent in the previous fiscal year.
Okay. And so how is this information, where is this information available? Where would I find out about this fund? Is it on the is it on the MCPD website? Is it in the, what is that, House of Ruths? Where do I find this information?
That information is everywhere. It's on our website. It is
Okay.
actually also with the FJC, Family Justice center. It is also, we have brochures in the courthouses as well.
Okay.
As well with our law enforcement. We go around and we provide community outreach as well to the community to let them know that this resource is there and available to them. We have a cohort of victim advocates that actually work with victims, and they meet them at the hospital, whether they're in law enforcement, they're at the police, at sheriff's office, or in court, and we let them know that this resource is there for them.
And so what's remaining in the fund since it was overspent? Was it overspent for FY24 or FY23?
It was underspent, and I believe the statute allows for flexibility for the fund to be non-lapsing from year to year, but it's like, it's an option. The funds aren't required to be retained in the fund from year to year.
Yeah, because I see the, under other information, it said later actions that may impact revenue or expenditures if future spending is projected, and it said the regulation does not authorize future spending. Does that mean there's no guarantee that the funds will be replenished? Or is that just standard language? What does that mean?
I believe
It's on Circle 9.
there's an appropriation made to the fund, and then victim compensation can be made within that appropriation. I don't believe it's an entitlement that it's like legally required for us to provide this level of funding, so that is a bucket of funding. But if the fund becomes extraordinarily in demand or something, that would be
okay.
something that policymakers would look at and evaluate the resources that the fund needs.
Okay. And do we have information about who receives these funds in our county? Who accesses and receives the funds?
Yes.
Are you able to provide that information to us, please?
Absolutely.
Thank you. That's all.
Great. So without objection, colleagues, we'll get the follow-up information, but great.
I'll include it in the council packet. And, okay,
Perfect. Awesome. Anything else, Ms. Young?
that's it.
All right. That was our first marathon session. There will be a couple more. Thank you all very much. Yes, we'll try to build in more breaks, I promise. That was my bad. But I will do that. So thank you all. With that, we are adjourned.
Thank you.
With 3 minutes.